recognised centres called BSG accredited centres, and they've got, so endometriosis is a very common disease. 1 in 10 people have it, and there's different types of endometriosis, really high volume, low complex, and low volume, highly complex disease, because it can affect anywhere in your body. Thorax, it can cause pneumothoraces, it can cause pelvic pain, affect your bowels, your kidneys, your ureters. And our story will be about a patient who has affected their kidneys as well. So the patient's symptoms are not always understood, and that's partly why they're ignored as well. And that can lead to a real big delay that I mentioned, 20 years, 8 years, on average 8 years delay in diagnosis. And for the patient, the lady, that causes a lot of frustration because they're knocking on the door and asking for help and not receiving any. And it affects them physically, psychologically, emotionally, because they're young, they want to have families, and it affects their reproductive age, having children, affects their relationships because they can have pain on intercourse as well, affects their mood, affects all sorts of things, and all these things add up, and they just can decimate someone. There's the suffering in silence. And at work, some people say, well, it's just period pains, and I've heard that so many times, and we really must sort of adjust that as well. Sorry, if you're a bit squeamish, turn away. I just thought I would just show some pictures to try and demonstrate what is endometriosis. And sometimes it can't be seen, but its effects can. Now, the 2 pictures on the extremes, the right and the left, if you were to show that to, a surgeon, a gynecologist, they might not be able to decipher what it is. Because endometriosis is a real chronic inflammatory disease that affects every part of the body and just brings things together. And it causes obstructions and strictures or narrowings. So this is the actual uterus. The ovary is full of endometriosis. The bowel is adherent. The fallopian tubes are all involved. And that's what you see in the endometriosis centres. And there's only about 27 of them. And the actual endometriosis consultant is very limited as well. There's a lot of gynecologists, but in terms of endometriosis specialists, there's very few. So if we do find a consultant endometriosis who's been trained really well, we really need to recruit or take advantage of that, because there are very few for whatever reason that there is. Again, you've got slightly low complex stuff, but it affects the bowel, the pelvis mainly. So we work a lot with colorectal surgeons and a lot with the urology doctors as well, because it affects the kidneys. So as I sort of probably mentioned before, it affects many states. I could be working with cardiothoracics, with diaphragmatic endometriosis or thoracic endo, with colorectal, with bowel disease, urology with kidney loss. And we also have a pain team at the Liverpool Women's Hospital. So Liverpool Women's Hospital is a BSG accredited centre. We're very fortunate because we've got big research element, and we're at the forefront of research. And we held an endometriosis research forum. We invited every research unit in the country just a few months ago in July, and we were just trying to be pioneers and expand the field of endometriosis and knowledge. So we're headed from the research here by Professor Dharani Pandima. She works really hard. She publishes about 30 papers a year. That's really active. We've got PhD students that we also supervise from the Royal. So we're working closely. They come from the Royal, they're colorectal colleagues, and they come to Women's and they do 2-3 years with us. I head the department, and I've got an endometriosis nurse. It's not a lot, one nurse, and she's getting a bit elderly. She's had a stroke and she's coming towards retirement part-time. So that's the sort of point that we need to address. We've also lost one surgeon. We've got Professor Shakil Ahmed, and he's really good. And he comes and he works really, really hard. He lost his colleague who went to New Zealand, and we lost Professor Cornford. But we've replaced him with Mr. Vish Hashtag. It's fantastic as well. Moving on to the actual patient. So she's a young lady in her 40s, has 2 children. She actually is part of our group. She's actually a solicitor, and she represents our hospitals at Hills Dickinson as well. She actually came to attention at the Royal. She had a big pelvic abscess, called it tubular ovarian abscess because it was the gynecological organs. And she presented in May 2023, and she was really unwell, very septic, and she required inpatient care. She was very well looked after. She got better and she went home. It was tubular ovarian, she actually came to the endometriosis centre because it was quite a complex disease. And we saw her there, and then we noticed that on the scan, she also had her left ureter was also very involved with the disease. So much so that caused dilatation and was causing disruption to her kidney function. So she had immediate work done. She had a stent put in to try and dilate and get around the obstruction. But during the course of events, she had another scan which showed that her kidney function had actually deteriorated to about 20% of normal function. So it was quite a lot of deterioration in a young lady. So we knew that in October 2023, we have a complex endometriosis multidisciplinary team meeting with gynecologists who are specialists colorectal, urology, radiologists, and nursing care. Now, we don't have much of a link in terms of administrative. So if we have to do cross-site working, that's when it falls apart a little bit. So at that time, we made a plan that we needed to do this complex case at the Royal, because we've got ITU, post-op care, because it's going to involve 3 different specialties. It needs 3 different consultants all together, and it needs to be worked in the robotic theatre, because that's the one thing that unifies all our working, is that urology are really good at robotics and open surgery. Gynecology do all 3, colorectal do all 3. But when we work together, the robot is the common ally, really. And the robot helps us achieve better clinical outcomes as well, which I'll come on to in a moment. So we needed all of our stars aligned, really. And we needed a link because I have seen the patient. I discussed it with my colleagues. And of course, when they're going to operate with this patient, it's really important that the patient also sees them. And so we know that there's delays in outpatients as well. So that can add an extra muster of delay as well to actually get the patient to be seen by each urologist and colorectal, and then have a theatre date booked for them. So we escalated to the executive level, and really well, we got an opportunity, and we were able to deliver care and operate patients doing well. But when we look at this case and we look at the endometriosis NDT, which I think is really key, there's 3 possible outcomes. Some patients that we're going to operate in gynecology at the Liverpool Women's Hospital, and usually they're operated within 52 weeks. That's the current turnaround. Then we've got a patient that we're going to operate at the women's, but we need the services of a colorectal surgeon. And those patients roughly wait between 1.5 and 3 years. So this is when the problems start, when we need joint workings. And it's complex disease with moderate harm as an effect. Now, the most important other category is when it's really complex. We need 2 or 3 different specialties. We'll need high level of post-operative care, ITU, HTU. And those patients wait between 1 and 3 years. And that's the category that our patient was today. And it's the most complex disease, and it could lead to severe harm, organ dysfunction. So really, just looking into the highlights of this case and the main issues, it was really challenging. We had made the decision in October 2023 that actually, you know what, we need an operation. It needs to be 3 specialties at the Royal. But to actually coordinate that, that's where it took a lot of effort. And just dissecting it further, we feel that if we had someone in attendance at the NDT who could link us all together, that might help improve the quickness or the efficiency. The other issue was that it was a patient from Liverpool Women's, prioritization or the targets, the waiting list probably falls on the Liverpool Women's, and then the Royal has to inherit it. Do they start back at square one? But you've got this patient who's waited possibly 8 to 10 years to get an opportunity to the Women's, probably waited a year to see us in the clinic, and then 1.5 years, 2 years. So by that time, that patient is really, really, really in a bad way. And so the Royal might see it, or others might see it as well. You've just referred her just, last month or 3 months ago. So that's something we've just got to add on, that the actual time is not 3 months or 4 months, it's actually years for every single one of those patients. So that's about prioritization, I suppose. We also, yeah, so other things is the add-on services that come on is the communication, the admin, secretarial, pre-op as well, and HDU and ITU. So just looking at possible solutions, I think the limiting factor is that there's two. We're very grateful that we've got 2 robots at the Royal, and 1 at the Women's Hospital. But I think in terms of clinical outcomes, you can achieve real big. There's big evidence in terms of meta-analysis studies. I've got 3 or 4 of them here, which show that actually less post-operative complications, less blood transfusions, less hospital stay and better clinical outcomes associated with the robots. And I think we urgently need to consider whether we can purchase another robot at the Women's and at the Royal, which would allow the planning. You know, once we've made that patient needs a robotic theatre at the Royal, there's a place we can actually go and do these complex cases. And equally, one might say, well, why can't you do it at the Women's? Why can't the colorectal neurology come to Women's? And I suppose that's possible. But I suppose for that to happen, you may need to consider HDU and ITU and that sort of thing, and what problems or issues that might bring as well, which, you know, we'll discuss a bit later on. We're in the process, as I said, I actually started work here to restart the Women's PhD Accredited Centre. There was 2 of us. Unfortunately, my colleague left. So we're in the process of trying to get another endometriosis consultant, which I said is like gold dust because there's so few that train that way. But we're actually in process, and we're hopefully nearly there to recruit one who's really good as well. I think I alluded to the fact that we've got 1 nurse who sort of got a lot of experience. Shame, which we just let her retire. But we need to actually recruit, I think, 2 band 6s to allow that knowledge to be transferred and succession planning essentially. I'd say there's increasing awareness. There's increasing awareness of diaphragmatic endometriosis, sciatic endometriosis, which we didn't know about before. But now all of our young patients in the groups, forums and stuff, are very aware of it, and they're going to be increasing, stuff. So we need to liaise with a lot more specialties as well, and heart and chest as well. So I was also thinking that maybe the endometriosis team could actually have a dedicated slot at the Royal, maybe once a month, 3-session slot in the robotic theatre that might help ease pressure with these patients as well. So the opportunities that we've got now that we're one big group and we've got lots of shared facilities and resources, talk about pooling patients so there can be enhanced visibility across all sites, so that we're all working together for the same goal, trying to improve our patient care. So ability to prioritise across and access dependent on patients' needs rather than the specialty. So you could have someone who's really at need in a specialty that doesn't get much access to theatre or to the interventions, and maybe expedite that and prioritise that. So improved anaesthetic support, that's really important. Critical care with complex disease, better use of theatre estates, multi-specialty operating, which is increasingly common up and down the country. Education and outreach, I think, is really important to hold these meetings with the board, with the public, train our junior staff and make awareness a lot better. This is just a few slides. This is a meta-analysis. It's real high-level, high quality of evidence from Shane in 2023, which showed that robotic surgery has less post-operative complication rate, less in needing blood transfusions, and less hospital stay. So I want to thank you very much for giving me this chance to be an advocate for our patients and have the opportunity for any questions.
Thank you very much, Ilias, and a really good story that highlights for us as we come together in the group the opportunities to do better for our patients in the way that we can work together. I'll open up for questions and observations in a moment, but perhaps come to Jim first for any reflection.
Thank you, Chair. Thank you very much, Ilias. I'm Jim. I'm the Chief Medical Officer. There's no doubt that there's a lot of interest in robotic-assisted surgery, and we're seeing that right across, including emergency general surgery and so forth. And you're making quite case, aren't you, for increasing the resource in that space. I suppose the observation I want to make as a general one is this illustrates a real challenge for us as a group, in that we are doing an enormous amount of district general hospital work, very busy A&E departments looking after our population, and we're doing more and more complex tertiary, possibly even quaternary. And I'm not certain that the commissioners really appreciate the costs that are associated with that. And it sounds like you have quite a, if you like, a book of work to work through. In other words, waiting lists which are maybe growing at this stage as a specialist centre. So it's certainly something we need to be very thoughtful about.
Thank you, Jack.
Yeah, there's a number of things in here I think that beautifully illustrates why we need to do what it is we're trying to do. Firstly, that ability to share waiting lists and to prioritise through need or complexity rather than just whoever's next in the queue for the specialty that has that theatre, which is a long-standing issue. That's one of the issues with so many different organisations in the Liverpool patch, I think, is that everybody's just focused on the urgent need of their particular specialty rather than across the jigsaw. What does that look like? And we can see, clearly from this presentation that we've got women disadvantaged by the capacity of a site that's not got the right specialism. So how can we pull that together? Robotics is a massive opportunity for the 5 organisations in LAS. We've got every one of those 5 trusts has got robots now. Talking about sort of scaling that up, the costs of that, managing a sort of long-term replacement programme. Very logical that we should do 5 organisations together and start to get the purchasing power surrounding that as well, because it's clearly the way forward. And also, as we start to think about how the 2 organisations can work as one effectively, we also know that we've got real challenges on the Royal site, but sort of underutilisation or free capacity at the women's site in terms of space. So again, if you were looking at that as one organisation, there's a lot of surgery that we do that's low risk on women at the Royal, but potentially could be low risk women's surgery at the women's, and then some of the complex things that need multi-specialists and robotic support could be done here. And those are things that as 2 organisations, you'd end up in a 6-month-long financial discussion around SLAs. Well, we could just get on with that stuff now. So I think there's a lot to be positive about in terms of what we can achieve. And I just wanted to thank Elias, because the lady in question emailed me as the CEO of both with this and just said, look, I'm bouncing back and forth and I'm coming to your urology department for another stent when this surgery can sort this problem, and it just makes it really clear why we need to do a lot of the things we're talking about doing. So thank you.
Thank you, David.
Thank you very much, Elias. Thank you very much. Just to echo whatever else is said around how clearly you've really identified that issue around, from a patient's point of view, it must seem absolutely ludicrous, the barriers that are put in their way, and it is ludicrous. This is really just a comment rather than a question, and it was around that whole issue of the succession planning that we have or we don't have in place for those specialist nursing roles, and that's a piece of work that we're now as parts of a group, because there are so many people who have got amazing amounts of years of knowledge and skill that probably we've not recognised as organisations about how fundamental they are to some of these services being rolled out. But it's also a great opportunity to be able to look at that for our future succession plans, to attract more people and the right people to our organisations who can see that there's a real clear specialist career pathway for them. And so this is certainly going to be a thing in my mind as a more of a motivating factor. So thank you.
Thanks, David. And Jack.
Thank you. I just wanted to ask a little bit about the first 2 boxes on your slide there, where you were doing the care at Liverpool Women's, and I just wondered, are those patients potentially getting suboptimal care? Because I'm presuming if they need ITU, they've been registered to come here. But have you got some patients that are in the middle there that could really do with being on the Royal rather than being at Liverpool Women's? Because I'll declare myself, I've been down that pathway and been in ITU. So, but it's really scary, isn't it? If you're on a site where you haven't got access to ITU, then it could be quite a difficult problem.
Yeah, no, it's a good point. I think the MDT is really key. We've got experienced colorectal urologists, gynecologists, radiologists, staff. So I think the decision making is really important. I think we do it quite well. I think out of all these patients since the last 4 years, we've not had to transfer anyone to the Royal. So we really triaged it at the endometrius MDT, and really triaged ones that we do feel need to go to the Royal. They do need to go to the Royal, as you say, for the ITU, the POCU and post-op care and higher level of care. I think it's all in that triaging.
Thank you. Matt, please.
Yeah. Really insightful presentation, Elias. And I think you've touched on the earlier on around endometriosis being very underplayed and not really diagnosed properly, and we're going to expect to see a much higher volume of patients coming through and correctly being diagnosed. And we absolutely do need to have that support and the pathway there to support that increased volume of patients. So I think it's really important to bring this to our attention and to look at ways that we can streamline, if you like, the care pathway to be shortened.
Thank you very much. You just reminded me of something that I didn't really touch on too much. Absolutely right. We're getting increasing complex cases, especially from, there's only two PSG centres in the northwest, here and Arrow Park. Friends of Chester lost their consultant as well, so they're sending referrals in. We're getting out of area referrals from Birmingham as well, so it's really difficult up and down the country. A big component is actually psychological care as well, because I mentioned all that frustration, all those 8 years, 10 years, then they're with us and they see us, and our nurse specialist does, this particular patient, she needed a lot of support, emotional support as well. And it was good that we can provide that. My fear is that, losing this experienced person or her cutting down the hours, she might not be able to provide that support. And that's really key because these are young patients. They look at their life, their relationships are breaking down. They've got pain. They can't go to work. They're stuck. And the way out is sort of, the support that we can provide. And yesterday or 2 days ago, I had a patient in a similar position, waiting a while. And I really couldn't think, have I got a psychologist or a counsellor that I can refer you to? And I didn't. So I think that's something that we're talking about as well.
Thank you. Sarah, then Jeffrey.
Just one, you've mentioned Arrow Park. It's similar to Jackie. I've been the middle case, but I was treated through Arrow Park. But from the point at which they determined I needed surgery, I had surgery within 6 weeks. So what's the difference in that system? Understanding the complexity of the different sites, but even in the less complex cases, what is it that we're lacking? Still be a year.
So I was with Thomas last night. I work very closely with Thomas as well. I think he also has this problem. I don't think I've not got this problem. It has. What it is the complex cases, the high volume, low complexity. So stage 1, 2, there's different stages of the disease. And in the picture at the start, I talked about the two extremes, but the other two, top one, might have been able to be done by a general gynecologist. So it's sort of not near the bowel, not near the ureter, so there won't be much damage. So those can be done in a DGH type fashion. But yeah, definitely Arrow Park will have problems in terms of the stage 3, 4 endometriosis disease.
Jeffrey.
But sometimes it's luck of the draw. Equally, it might be a 30-minute operation or 40-minute or 50-minute.
No, I was complex.
Yeah. So I can't answer your specific, but I know that there's problems up and down the country.
Thank you. Jeffrey. Really good presentation. A couple of points, if I may. I think picking on David's point, as we come closer together and integrate, are your thoughts that actually recruiting consultants who clear that rose hen's teeth across the country will become easier? You can advertise this kind of holistic and integrated approach. Will that make life easier? I think that for nurses and for that first point. The second point picks up on the point about the commissioners. And I was at the Heart and Chest, especially never understood why complex aortic surgery was so expensive. As I was listening to you talk about the more complex cases, thinking the pound signs are stacking up and you won't get paid probably what it's there. So there's an influence in the commissions to really understand that, because as you get better, you will get cleared across the country. You become a nationalist centre. And my last question is,
So, your last question, patient's much better. She's happy. Yes, she's really good. Your case about the commissioners is really important, isn't it? Because I'm not sure what the commissioners want from us, but if they want clinical outcome, it's there. You've got quality. You've got patients who are being treated. That's important, and I think there's a need. Like for example, at the moment there isn't a diaphragmatic or thoracic centre. Not that I'm aware of. There may be a private one, but I'm not aware of a national one. And we've linked up with, we're linking up with Heart and Chest because we've got 3 patients. So they're very, very happy to be on board. They're very excited. They want to work with us. You know, the need, but the consultant, the CD, very happy to be involved and stuff. But you know, so we want to. But commissioning is it was a little bit disappointing.
The recruitment, as you
yes.
get more integrated
Yes.
this kind of service,
Yeah.
will that make recruiting this clearly rare species easier?
Yeah.
As means in the centre of excellence.
I think robotic surgery is, for want of a better term, sexy amongst the clinician surgeons, and I think they want to go to these centres because they see these as pioneering, forward-thinking centres. So I think they are able to attract. We're able to attract the best people. We're able to retain them as well, which is really important. I think yes, for sure. I think robotic will definitely help in that. Being a centre, being part of a bigger, group would help as well. And having backup, because the last thing you want is to be stuck somewhere with a patient that's gone off and you've got nowhere to go. I think something like the Royal, which has everything.
Thanks, Lewis.
Thank you. I think the last point from Mike, Jenny, then I'll come to you to sum up before you.
Thanks. So it's a process question, really. So within all of this, there was a request for 3 sessions a month. So in the new lexicon, how do we resolve those kinds of ideas and those kind of processes?
I can that. So we're doing it. We've just literally doing an exercise at the minute between Aintree, Broad Green, and the Royal, which is doing we've grouped all the theatres across all the floor plans, and we're doing that piece of work between the hostel leadership team. So I've written down a note. The next thing is to do that same exercise with the women's team, and we'll work up the new schedule, which is going live in the next few months. So we'll just include them as part of that process now.
Thanks, Natalie. Very good. Yes, Jenny.
Thank you, and thank you, Elias, for coming this morning and taking us through that journey. I think it's really important that we as a board hear the stories that these ladies face day in, day out, and the challenges that we face. But I think from my point of view, just really excited about the opportunities now that we've got moving forward and the ability to make some of this better and make it more robust moving forward. So thank you.
Thank you very much, Elias. We look forward to following progress going forward. Thank you.
Absolutely. Forgive me, I have to go back to women's.
Sure.
So if you've got any questions or contact me, please share my details. I'm happy to answer any questions.
Thank you.
Thank you very much.
Here we have 2 sets of minutes to approve, please. Firstly, from the Liverpool Women's Hospital Board meeting, which took place on the 10th of October. Are there any points of clarification, accuracy? Anyone, guys? Thank you. Can we approve those minutes, please? Thank you. And from Liverpool University Hospitals meeting on the 31st of October, likewise. Any points? We approve those two. Thank you very much. I think, Daniel, the items on the action tracker are pretty much closed.
Yeah, so there are 4 actions. We've taken forward actions that were on the action logs from Liverpool Women's, of which there were 3, and 1 from Luft. The Making Data Count training, that's the longer standing one, is scheduled to take place with board members on the 4th of December. In terms of the governance arrangements of previous actions on the chair's log, they've all been transitioned over to the new arrangements, and obviously any issues that are escalated through to the board by the committees will be captured by the action trackers going forward. The thematic data reviews of the Freedom to Speak Up Guardian reports, we've worked with 2 Freedom to Speak Up Guardians, and their report that will come to January's Board of Directors will include a little bit more information on thematic issues over a longer period of time. And then separately today, we've included questions that were asked by members of the public in advance, but also members of the public on the day at the annual members meeting that was held recently. There were 14 questions that are appended to the action tracker, and the majority of the questions have been answered, and the information and the answers are actually within the pack. There's a few more that we need some further information. The plan on those, Chair, is that we will share them also back with the Council of Governors from both Liverpool Women's and Luft, so they can track the answers that we've provided to members. And obviously we'll bring them back to next month's Board of Directors until all of them have been answered with sufficient evidence.
That's very good. Thank you, Daniel. I've not been notified of any urgent matters arising, so we'll go straight into James, Chief Executive.
So we've got first time of the two statutory organisations. So what we're going to do, just for board members' awareness, is that for now, up until the end of March, to keep everything on the same format for this financial year, you'll see the integrated performance reports for Liverpool Women's and for Luft separately. We are working on the integration of those two reports. Now, what that means is you'll still get all of the metrics of both, but there are some that are common and can be brought together, although not a huge amount that are common. So from the 1st of April, we're reporting our sort of new structure, but for now, keeping both in view as they are. So you'll see in my CEO report, which I'll come to in a second, on the performance elements. We're now drawing out from both of those the key statistical changes that have happened within the last month. But in terms of the report itself, I think most of it is self-explanatory. I wanted to reference, obviously, that it marks the first iteration of the UHL group, and that's a brief explanation in there for public around exactly how that works. I wanted to just mention something that wasn't in the report, happened after the report was published, which was the HSJ Awards, also its Journal Awards. The group, the two trusts, both won awards that night, which is excellent. One for the Liverpool Women's Hospital, which was, I always forget the title of this one, Matt, what was it?
Driving efficiency through digital.
Driving efficiency through digital, which was a great recognition of the team that did the EPR deployment and some of the other digital work that followed over at Liverpool Women's. So they were the winners on the night, and the team who were previously in Luft around Scout School, which you've heard about before, which is how we bring our international recruits into understanding Liverpool, the history of Liverpool, and welcome them to the city and so on. So that won an award that was around staff engagement. So it was great to see both parts of the organisation recognised on that. I did want to just note the improvement in maternity services, which the board is well aware of, but we had a regional maternity team visit on the 21st of October, and the feedback was really excellent. And in our most recent system oversight group, again, that was reiterated that the progress was really tangible around maternity services now at Liverpool, and so that was great to see as well. There is an ask in the paper today, which is that we obviously have got the new processes in place now at Liverpool Women's to reflect the same way that we operate for hospitals within the group structure as was at Luft. So we've got the terms of reference for the management board that effectively runs the Liverpool Women's organisation attached to this, and I am asking for approval from the board of those today. They are attached in the annex associated. They're effectively the same as the membership and the configuration, and the terms are the same as we use within the Luft hospitals. There are some slight differences, obviously, with direction midwifery at the women's, but also some of the corporate engagement as well, but they are very much the same. So that's all been worked through, attached to the sort of COVID governance manual. So we just need an approval on that, which perhaps I'll take at the end, Chair. On the performance side of things, as I say, split into two parts at the moment. What I wanted to draw attention to, although there's a number of things in there, CDT, so C. diff cases are still showing deterioration statistically significant. Now, I know David gave some assurance on this in terms of we're not outlying even though our numbers are increasing, and you may have seen quite a few reports in the HSJ recently and elsewhere about growing numbers of CDT cases across the region. So at the moment, what we know is our numbers have gone up. We're assured by the things that we're doing to try and mitigate that. So the input measures, the things that we're doing to try and combat that are right. But the overall numbers are still higher than we would like them to be. When we look at that more broadly, we're not out of kilter with the rest of the country because it seems to be moving in the same direction. However, we would still like some more assurance on that. So I know Jim and David have both been having further conversations. So
thank you very much. So just to iterate, we sit below the northwest average at 100 days for CDT. Obviously, one case for one patient is too distressing. And because of that, and because the numbers are increasing, and particularly with other infection prevention issues that we are noticing, we are taking advice from NHS England, and we're doing some joint work with colleagues from other organisations and NHS England to come and have a look at our processes, both our processes for monitoring and reporting, but also some of those very fundamental issues about people's behaviour. And so that process will be taking place over the next few weeks.
Thanks, David. So I think for today, again, it's the second month I think we've discussed this. So we've got some reassurance, but I think we just want to see a bit more evidence as to what other things there might be, or is there anything else? Friends and family test has been good largely, but you can start to see the bite of winter pressures now. So the experience is deteriorating into the ED departments, as often happens in the winter period. And again, that if you look through the charts, that's sort of an annual occurrence, but it certainly does display the challenges we've got around long waits in the department coming into winter with little egress still from the hospital, which we'll come on to in the site reports, no doubt. I wanted to also mention that we've got a number of metrics in the Luft report that we talked about last time at the board that were sort of statistically in good control, but at 1 or 2% under a sort of arbitrary target measure. We're going to put some of those up next week when we come to the board strategy day when we talk around the SPC work. So we had a good discussion, for example, around pressure ulcers the other day, where there's a good example of statistically being well managed, but slightly lower than the number we looked at. In that, we think there might be something around the, it was delirium dementia, apologies. And when we looked at that, it looked like it might be that we're counting a numerator that's sort of going to make sure that never happens. So we'll be able to do some deep dives into these next week, and then hopefully reach a conclusion as to what the right target should be, but they're all statistically safe. Sepsis isn't in the report this month deliberately. Again, we've talked about that a couple of times in the last couple of months. Our performance is good, our outcomes are good, our mortality information associated with that is good, but the metric has changed. So we could have left in the old measurement, but that's no longer the measurement that's being used regionally, nationally. So the new measurement will fall in from the next IPR in December. So there's nothing concerning around that other than the need to change the metric now in December. And again, similar stories on e-news, just around, again, good compliance, but slightly below that overall target. So we'll pick that up when we meet next week. For Liverpool women's indicators, we've got quite a few that are performing well. So we are seeing good improvements on the elective weights and other things as well. I was really pleased to see the anti-racism trend down to the 80% mark. That's well ahead of schedule as well. So that's really good. I think the ones that we want to take a look at, again, we will come into these next week, is the way that the PSIs are reported and the never events are such that using a rolling mechanism sort of leaves us in this constant thing of it looks like it's continually worse when actually it might have been a normal variation and no further happenings performance. So we want to bring that in line with the way we do it in LUP so they're consistent. But again, we're going to change that at the end of the year. So we'll touch on that next week about how best to interpret that data going forward. But at the moment, we don't think there's a problem there. We just think that that's around the way we're displaying the charts, perhaps by using those rules. But all of that will become consistent. So I think they were the key things, Chair. Again, just to go back, I just needed approval from the board on the terms of reference for the Liverpool Women's Hospital Management Board. But other than that, they were the key issues.
Thank you. So we'll take questions and comments, but let's deal with the terms of reference issue first, please. The reference, this is pages 32 to 36 out of 635. We can, any questions on the terms of reference before I ask for approval? Thank you. Can we approve that, please? You consent, Jenny?
Yes, I am.
Thank you. Approved. Any other questions for Jane? See you first, please.
Not so much a question, more an observation. James, you referenced the anti-racism work, and that was picked up on at the annual members meeting, and really people were very happy with that. All I want to say, I suppose, is that leads to expectations, and undoubtedly, you know, Women's has done a lot of good work on that front, but there's going to be expectations about representation at governor and non-executive level as well going forward. So I just want to make sure that we don't lose sight of that, being caught up in the work that we're doing within the hospital, because ultimately there's questions of representation, and as the community in our area gets more diverse, then this is something that
Yeah, I may just respond to it. Absolutely, easy. We've got, so the good thing, and so the Liverpool Echo have been in touch, they want to work with us at the Women's to do a story about some of the work that's been done over the last couple of years, because they are rightly focusing on the outcomes, as we know, for black women in maternity cases being worse and all of those things that we've discussed in the past. So they want to look at from a positive angle, the work that we're trying to do on racism there. Within the Luft part of the organisation, this organisation commissioned a report back in 2020, I think it was, the Globus report, which was then never saw the light of day. And again, that potentially about going into COVID, I don't know, none of us were here, but it didn't make its way out to staff, so they never got to hear that back. We subsequently located that report, published it to our staff, and it's pretty horrible. So we wanted to share that and then look at the work that we're doing here. What we're trying to do is bring the two organisations' work together, because the Women's is further ahead in its ambition around this stuff, and we want to use some of the things like the anti-racism methodology over here in the Love part as well. On the representation point, absolutely, and this is something we keep pointing out over and over again. So there's two things there. One is about getting people into senior leadership roles within the organisation. It's a challenge. You can see that we're having some success in that from some of the metrics, and we've got the number of global majority staff now in leadership or management roles is increasing, which is great. We'll transport that work over here to Luft. The logical question is, our board is not representative as well, as you say. And one of those things that we referenced in papers to the board a few months back was how we now start to get that balance right as well. On the non-executive director front, obviously, David is addressing that through LASP and looking to partner organisations, whether we can start to import and bring in NEDs from across sites where we can improve that representation as well. So I'm confident we're doing lots of things about it. It just feels very uncomfortable right now because it isn't where we want it to be, but you're absolutely right to raise it.
Thank you. Sarah.
Just one question, forgive me, this might come up with the risks to defer it, but noting the stillbirth rates over the last 3 months are materially higher than they've been for the prior 12, almost double now. And I know the numbers are still relatively small, but it is a concerning trend. Has that come through the risk committee, the quality reviews? Have we got any understanding of that as a quarterly outlier?
Do you want to come to that in the Women's Management Board report? Because that's where it would feed through the quality and safety metrics there, because that part of the IPR is there as well. So, Jenny, do you want to do that there, or do you want to do it now?
Do it as part of the whole.
Yes.
All right.
Is that okay, Sarah? Thank you. Thanks, please.
Okay, David, can I ask about the A&E performance? Because we can see the A&E performance starting to deteriorate, but there is no great increase in the number of type 1 patients. So I'm wondering what's going on the ground. This corridor care is starting to back. Is the patients can't flow through the A&E departments now because we don't have spare beds available in the hospitals? Are we being overwhelmed with other walk-in patients? What exactly is going on the ground?
Not only spare beds since 2020, but you're right. It is more around that exit block and some of the acuity issues. But Nat, you may want to come in on this.
I'll give you, I think it's slightly different across the two sites. So at the Royal, there is no ability, obviously, for escalation capacity. But at the Royal, our length of stay metrics are actually improved and have maintained that improvement. We haven't seen a deterioration yet in that, which we would usually lump in acuity into winter. But we are seeing at least 20 more patients a day walking into the Royal A&E. That has been the case, you'll see on the ITR from mid-September. When I come on to our challenges around our handover and corridor care, it directly correlates from exactly when that started to the pressures we're seeing. So we are seeing that at the Royal. It's slightly different age. They have had some more challenges, I think, around exit block than we're getting at the Royal, and we can see that in the IPRs.
Peter.
Yeah, so thank you, and it is slightly different. I think Greentree has the double whammy in terms of the A&E performance. So if you look at the IPR, we have seen a slight uptick in criteria to reside patients. We saw it come down nicely with the work we were doing, but it has now started to go back up, which is disappointing. Is the work of the North Mersey integrated discharge programme really to address that, and there's several things that we can do on that around P1s and the TOC and the brokerage changes for the P3s. In terms of entry as well, we are seeing increase. If you look at our IPR, there is increased numbers of ambulance handovers and ambulance handover delays, and that's a concern. I'll come on to that again. And then this is sort of the final. So you can see all that heading into the winter challenges, Tom, which is really where you're going. I think also just on top of that, if you look at our flu prevalence data in the last week, what we have seen is a significant rise in flu cases. So we are now seeing that. That's the extra challenge on the front door. I know from some personal anecdotal evidence of my wife's a paediatrician, we're also seeing in the community increased RSV as well. So it's those double whammy of viruses that are seeing more. We've sorted the problem in the entry now. There was also an issue in our Sudoku. We've moved, so there was a bit of a reduction in our use of Sudoku as we moved down the corridor. So that also helped with our overall AE performance. So it's multifactorial, but.
Any more points on James' report? Okay, thank you. Let's move on then to the corporate group-wide risk report.
Yeah, so again, we'll pick up probably the root cause of these issues as we go through the reports from each of the hospitals. But see if I can bring the reports up. Sorry, 1 second. Why is that not working? Okay, sorry, technical problem. So yeah, we've got the very similar group of risks now. We've got on the outpatient risk on the overdue follow-ups, that still is a 12. We discussed that at length at our senior management board 10 days ago, and we think we'll see that one start to reduce from the next month because a number of those are now getting reviewed. They're being reviewed by all specialties, which was a question last month. So I think we're seeing some inroads into that. So we expect that to reduce. The work on the 65 well, we've had a slight increase as reported into the ER. So that's one that we've held at 11 for a while, but has been increased to 12 in July. And it's still a 12, we feel, at the moment, just because of those pressures. And it's back to, that isn't a whole organisational problem. That's a small number of complex specialties, which we've mentioned before, so head and neck in the NC in particular. The two financial risks, I mean, we'll come on to these, no doubt, as we get through today's meeting. So the cost improvement programme, the challenges around that are different at different sites. So the Royal and Aintree have probably got slightly different challenges in their financial recovery, which the team will come on to. And then that whole financial balance, longer term controls work. I think on that one, that is still featuring as a 12. It's one of those challenging things of our financial controls are now significantly better and almost a sort of regional best in class, and we can see that in our run rate control. So that's a good thing, but it's still not going to be enough to get us to where we need to in terms of that financial balance without the material other issues that we need to resolve. So Rob's put some comments in around what we're doing around the PwC work, which again we'll come to later. We have got later on in the strategic discussion in part 2 about where we're heading, a further exploration of that as well. So there'll be plenty of time to discuss that there if not now. They were the key 4 that we reported. So
there's a consistent theme to these risks over a number of months now, in the sense that we're about to see some progress, but we haven't seen it yet. David first.
Yeah, thank you, Chair. On the follow-up outpatient appointments, as you say, that's been around for some months now. I just wondered when we have our session on making data count, whether we could do a deeper dive to understand the type of outpatients that we are not following up on. I'm conscious that for many, many years, commissioners have been telling providers they're seeing too many follow-up outpatient appointments. And I'd just like to understand, are these outpatient appointments perhaps that could be better managed with a patient initiated follow-up and what we're doing there? So just a better understanding of the data, really.
Yeah, so absolutely. So like I've said in previous months on this is an absolutely huge number. It exists in every hospital across the country. We think it's a risk because of the way that the sort of NHS performance framework works. These are the patients that get forgotten about because they're not one of the national indicators if you're not careful. I think, as I said several times, there is never going to be a solution to this problem that is seeing everybody in the same way that we've always done it, without either an injection of tens of millions of cash and loads of new people, because clearly there's capacity and demand mismatch. What we really want to do is come up with a different way of managing that cohort. So we'll touch on it next week in some of the Make a Data Count work about what they are. But the following week, when we have our strategy and partnerships committee, a really important part of the strategy is this element of our population that we've looked at through that segmentation work that you've all seen, who just need a diagnosis and a treatment plan. We know that within that whole outpatient number, about 30 to 50% at the point of actually having the outpatient appointment, just have a conversation. So it's not that they're waiting for huge complexity of, imaging or operation or diagnostic testing. A lot of it is just around different ways to facilitate that from a very antiquated sort of referral system. So one of the big challenges for next year is going to be, can we create different stream to waiting for ages in a referral pathway post-COVID or coming to the A&E? And we need to create a different stream for people that we can see quickly, get answers to quickly, and support GPs with quickly. I think that's going to be the logical way to resolve this problem, rather than trying to buy it out with more and more capacity. Because as you say, a lot of it is stuff that would be avoided. The current NHS systems don't really allow it, they force it down one route or another. So we'll definitely get into that in the next two meetings.
Thank you. And just on the follow-up outpatients then, just for the avoidance of doubt, the report still says most specialties have commenced. Can we say all?
Yes,
said this last.
they have all.
Yeah, that's an error. Sorry, that should say all.
Yeah, just for the minutes. And also, I know this is difficult, but this point about restrictions on admin and clerical appointments is having a. How many admin and clerical staff are employed, Heather? Thousands.
Yes.
Yeah. So is that, are we doing everything we can to try and take this
An awful lot.
reduce this risk?
Well, we are, but an awful lot, to be frank, and again, this will be the same in every organisation, is a capacity and demand mismatch of these patients means a lot of this checking, going in and validating pathways is done as overtime. It's been done as extra hours. It's been done all the things that we're also trying to constrain because of cost problem. So it is a real issue. And we're already starting to see an emerging risk on the 52-week waiters that's down to validation of pathways. Because, again, back to the sort of NHS systems, a significant amount of RTT pathway reduction is validation of the pathways to check they're not duplicates, that they're not incorrect, that that patient did turn up or didn't. And that's all done by administrators in extra time. And that is a real problem for us now. The logical solution to that is not to keep adding so many people to that waiting list through a different care model, which is what I was just describing. But also what we'd really like to know is, can we use and benefit from different digital solutions that will help us here? Because, again, I was having a conversation just a week about the use of coding data that could risk stratify. Because we're sitting there looking at a big backlog of patients, not knowing whether you're going to ring them and they're going to say, yeah, I've not been seen for 2 years and I'm chronically ill. Or whether you're going to ring them and they're going to say, oh, I got seen 2 years ago, no one's taken me off the system. So there are methods now that are becoming more reliable to use coding data so we can stratify risk. And then what we'd be able to do is give better assurance that we're seeing the right people who are at the most risk, and the ones that aren't are probably more likely to be your data clarification errors. So it is a real issue. It's not an excuse, but it's a tricky one because it defines a different pathway. And at the moment, we're still very reliant on almost paper transactions to validate pathways. We're not on our own in that. That's a common theme across the NHS. Okay, next thing.
Thank you, Chair. So, in support of an agreement of what James is saying, I had a meeting yesterday, and we must be working on, I'd say, about 15 digital enablers to do exactly what James has said. And there are a range of operational people involved in that, of how we can digitise, reaching out to patients, making sure plans haven't changed, and also to remove any duplicates, etc. What I did want to say as well, in response to what David is saying, so at the moment we are high performing on the PIFU pathways against the target that's been set. We are looking at different ways of managing patients, the patient-initiated follow-ups, and I also think we should just note that we've now put just under 2,000 admin staff through the Admin Academy, and that's really important in addition to what James has just said about when patients are administered on the system, they are correctly coded and their pathway is recorded accurately. We've also now reached out to our colleagues at Liverpool Women's, and their admin staff will also be going through the same programme. Thank you.
Okay. So how did you want to come in?
Just Matt and I have been speaking about this earlier today, and it's, I guess, back to my day job. We're doing exactly this within Cisco at the moment. I'm going to share some information through Matt, but we've started an alliance with healthcare trusts that is looking at exactly that, so how you digitise, how you use AI, large language models to start to automate the pathways and use that intelligence to, you know, mediate against some of the human errors. So I think 16th of December, we're hosting Matt and the team, but there's a lot that we're developing that we can make sure comes into this trust.
Very helpful. Sorry, just on the outpatients, that when do we think we're going to be de-risking this?
Well,
so we reported at the last meeting, we want to understand the scale of the problem by the end of March. That doesn't mean that the risk will go away. It means that we will understand the scale of the challenge ahead. We will have a cleansed position, and we will be able to report on the capacity shortfalls by specialty in those patients that are overdue their appointment, which we're not in a position to do. That's what we're working through now.
All right. Thank you. In the report, Rob just put a marker down in the financial service risk 7963. In James's report, says a delivery risk of nearly 62 million on the cost improvement programme. You just pick up when it gets to your report what delivery risk means on all of them. Okay, thank you. So we've got the integrated performance report appended to the list, and we picked up some of the issues. I think what you want to say about that now, we'll pick that up after the slides.
On the IPR?
Yeah.
No, I mean, I've already commented on the areas that I think we should draw out, but if anyone does have any that they want to ask specific questions about, now would be the time.
Okay. We'll get a more richer flavour of some of these challenges we go through the slide. So we start. Natalie.
Thank you. So I'll start with the key risks, and I'll just group them if that's okay. So if I start with urgent and emergency care, from a royal perspective, you'll see in the IPR that we've seen a significant increase in ambulance handover time. So the average handover time is 56 minutes. We were close to the national aim of 30 minutes through the summer months, but that's now increased, and we've seen the over 60-minute delays increase. I suppose on a positive, whilst under this pressure, as I've referenced, we've seen increased attendances. We are maintaining really, really high performance on time to triage, and we've maintained the improvement on time to see a clinician. And when we see the national data set, we're in the top quartile for those those areas. The issue remains with the time patients are then spending in the department awaiting admission. Now, on the risk, you'll see for the Royal that delayed discharges from the hospital was at a 13 and the division have downgraded this to an 11. So it's still a serious risk, although we have seen positive metrics at the Royal. So we have seen improvements across 7, 14, 21 day length of stay. Our patients who are in hospital have been there over 60 days, the lowest we've had it in over 18 months. And our not meeting criteria to reside was up at 150 in April, and it's now at steady about 115. So although that is still nowhere near national best practice and where we want to be, we've maintained that level of improvement at the Royal since June, July time. The key risk as well we want to review is we've had a long-standing risk around mental health delays in the department. So we are going to close that risk on the basis that the risk that is in the pack describe the things we need to change in the emergency department. So we've made some physical estate changes to the mental health hub on the advice of Merseycare and what would support patients when they are in that hub. That was related to doors, provision of beds in the rooms, etc. We've reviewed the ops policy in the department with Merseycare, and we have a new ops policy in place that Merseycare have put in place for when patients are in there, the observation while they remain with us. And we've done various things around escalation processes for long stay with the ICB. So we think that risk needs closing, but a new risk will go on because the risk that remains is that the patients are staying still in the emergency department for prolonged periods of time. So the division are going to rewrite that risk and a new risk will go on to update and reflect the updated position. You can't see a risk on there at 12 at the minute around the initial ambulance handovers because we had such positive improvements through the summer. The division had downgraded that, but we discussed in HMB that now, based on the recent metrics, needs upgrading again. And you'll see in next month's report that will be above the 12 again for ambulance handover delays. From an elective perspective, there are a few risks on there grouped around elective recovery, but some positive movements. So the risk 8,000 around endocrinology, that is resolved. That risk is being reduced and we will not have 65-week risks around endocrinology that the division are managing. There was a risk 8382 showing around the theatre monitoring equipment, which you'll remember we mentioned last time. We confirmed at HMB the equipment has been purchased and we have the rolling plan for that now. So again, that risk can be removed. And we had the risk around endoscopy. So you'll see in the IPR, this is where the Royal is not achieving the DMO1 standard around the 6-week diagnostic target. When we took the enhanced rates, the endoscopy staff did not want to do the additional activity on a weekend. They stood that back up in November. I've seen the activity reports, we've seen increased endoscopy activity, and we now have a trajectory to meet the DMO1 standard for February. So again, based on me seeing at the end of the month that we've hit our trajectory, we will reduce that risk as well. 6516 was a risk that remains around breast, and this is primarily breast cancer pathways. So this is long-standing vacancies we've got in particularly senior radiology posts in relation to breast. This is a national issue in recruiting to these posts. We have agreed a continuation to the end of March to use insourcing to support with the breast activity. So based on that, we have agreed that the breast risk as well will be reduced because we will be able to maintain the cancer standards. So the only really remaining risks on elective that I would flag that are still at a 12 is the risk relating to the liver MDT. So this is an increased demand that we have around patients that need to go to the liver MDT, and we don't have enough capacity currently in our weekly MDT. This risk spans cancer services, gastroenterology, liver, a number of specialties. So we have a plan in place. We're working cancer services corporately, a good coordinating a group to look at this and how we increase that, but that risk will remain until we get a plan to increase capacity. And the other risks that remain that have been there for some months are around dental. Again, these are really hard to recruit, national issues around some of our dentist posts. So we are doing what we can to increase capacity, but they remain a risk, and we have some increased waiting lists remaining in dental. The other risk I just want to touch on that is 12 plus is the cleaning standards risk at the Royal. So a couple of bits to note is that we have touched previously that we were having industrial action, which was taking place quite regularly at the Royal in relation to our domestic staff. That has been resolved in months, so we're hoping to now start to see some improvements when we don't have that disruption to the services. There is a review of the staffing taking place until we get that staffing recruited and in post. that risk remains. But if we triangulate it with the actions we've been taking on a temporary basis to support the site, you'll see in reference to the CDT cases, that has decreased for a second month in a row, and we had 6 cases. So whilst we're just working through the sustainable long-term plan, we are seeing positive improvement and feedback around IPC. The other bits I would just draw out is obviously the financial position. So we had 6 million year-to-date deficit we are reporting, but the in-month position in month 7 was the most positive month we've had at the Royal, and we broke even in month. That was primarily due to a strong income performance. So we overachieved income, and we have seen some positive improvements in the recovery plan in relation to the temporary staffing controls and the enhanced pay reduction. There are 2 things I think that are the main concerns at the Royal. One is in the IPR, you will see the sickness absence has increased. We're keeping a close eye on that, but that obviously does put at risk our temporary staffing controls. We're managing that, but we need to know that I think going into the winter period that will be a challenge. And the main thing at the Royal is the CIP. So we have, as I've said previously, we've got a £40 million recurrent CIP target. So far, year to date, we've delivered 13.6 million. That equates to 21.5 million full year effect. I think the positive is that almost just over 20 million of that is recurrent. So what we are delivering, 90% of it is recurrent, but we are still away from the total. We have stood up now some workshops throughout the next 2 to 3 weeks with the divisions, really looking at how we pull back some further CIP in the last quarter, but also planning for the next year's significant CIPs as well. So that's where really my big focus is at the minute with the divisions, is what we do about the CIP standard at the Royal. Just other bits on performance in the IPR, I think I've touched on most of it. The only other thing I would touch on is you can see elective improvement continues. So the number of 52-week patients over 52 weeks on the waiting list is coming down. We've got 12 patients who remain over 65 weeks at the Royal, and I'm now putting the challenge in that we need to have 0. We're now on single numbers, so really pushing the teams around. This is PTL management, and I would expect 0 breaches at the Royal 65 weeks. So that will be my drive now with the teams over the next couple of months. And then just the other bits we noted in the HMB. I think the board will remember this time last year we reported we'd had the trauma peer review, and after the move into the new Royal there were some significant concerns raised around those standards. We've had that review undertaken again, and we've had the formal report, and they have noted the significant improvements that have been made, and they have approved us as the trauma unit and meeting the required standards. There are recommendations, as they're always are, and they're coming through our clinical effectiveness committee, but a much improved position. And a thank you to Aintree, because I think it was noted how well the trauma unit and the trauma centre are working together between the side. And then the final bit to note is we gave an update at HMB around our Right Patient, Right Team, Right Time programme, which I chair with all the divisions and the clinical leads across the specialties at site. So this is focused on our urgent and emergency care improvements. And just to note 2 significant things that went live in month. So we are the tertiary centre for renal nephrology services. The renal team, the clinical team, came forward with a proposal which we supported to implement the same-day emergency care unit on the Royal site. That has now, they've trialled that for 3 weeks. 66 patients have been through that, 43 who were heading to ED, and they deflected to the same-day emergency care unit. And only 7 of those 6 patients got admitted. Previously, 43 would have come to ED, and they would have streamed them all up to a renal bed on level 7 in the Royal. So we're seeing some really positive feedback around that. So that was a clinically led improvement programme that we have supported. And the other one is we have stood back up the GP phone line to the AM acute medical unit. That means our GPs now come in and have direct conversation with an acute medical consultant before they convey a patient. Again, we're getting really positive feedback on that. That is the first step, and then we will look to open that to the paramedics and community services. But we just want to work through that with GPs and iron out any teething problems. But again, they're 2 significant improvements to UEC at the Royal. That was.
Yeah, that's very good. The first time in your update, you said something positive about Aintree, so we.
That won't be specific. I'm working on
it. Just a bit sleepy deprived. Okay. Points, questions, thoughts on the Royal site update? Yes, Mike. Thank you. For the first one, three things. Maybe first one for Chris. If we've got 3,000 people waiting 12 hours in, so that's 100 people a day. That's plenty of stories, stories for the Echo to write about non-performance. Are we doing something proactive about that? I think the second and third questions, you might have said it, and apologies if I missed it. In terms of A&E increase, is it increase in volume or is it increase in acuity?
Sorry. So initially it was increasing volume mid-September, but then in the last few weeks, we are seeing the increased acuity scores. We can see it through the clinical prioritising in ED, and as Pete noted, we're seeing an awful lot. So we've respiratory capacity is significantly stretched. So I think now we're seeing the acuity as well as the increase in attendance. I'm sorry, I forgot to mention, I should know, we had CCD corridor care, haven't we, at the Royal? We are back now to utilising the corridor to offload ambulances and make sure we keep handing the patients over as quickly.
Yes. In terms of waiting lists and the government's pressure on waiting lists, is there a government position as well as our own position? So we're reporting whether waiting lists are going up or down. Is there a position that we're supposed to be at any point from the government's point of view, or is going down virtuous and going up not virtuous?
Well, we obviously want it to go down. We're still maintaining that it's still a 65 week. We're obviously working through the plan. We'll get the planning guidance in the coming weeks, which will outline the standards from April that they expect us to be working to.
Thank you. Tracy, please.
Yes, very comprehensive report. I'm just picking up because obviously I went around the Royal and I went into I went into the mental health hub. So I'm very pleased here that actually have got the beds, etc. there, because I think it's unrealistic to expect those patients will move on as quickly as perhaps you would think. You know, quite often they present in A&E, don't they, come a distance. So there was one person who'd ended up in Wales, and therefore actually trying to get them back into you know, where they live takes some time. I think it isn't also treatment sometimes, because if they've had drug abuse or something like that, or alcohol, they have to effects have to wear off, don't they? It can be assessed. And then if they're being sectioned, then they have to be sectioned to a particular bed. You can't move them from one to the other. I think all that takes time. So I think the idea that they have a mental health up there and actually you make it comfortable, because I think it's realistic they are going to be staying a little bit longer than most people coming into A&E. So.
Yeah, and I think that's been one of the challenges in that Merseycare are clearly the experts in this, and I think it was about balancing that risk. So I think it was that risk of putting things in the rooms that would be a risk, clinical risk to that patient with their presentation. But what we were discussing is, they are in here for a long period of time. So I think we've just worked with Merseycare to try and put everything we can in place to accommodate the patient as best we can, whilst not putting them at any further risk.
And then having seen it and kind of do that, that's good. That's positive. Thank you.
Thank you, Tracy. We've got next Jacqueline and Pete.
Thank you. So can I just ask about the mandatory and role specific training of medical and dental staff? It's suggesting that there's a 25% non-compliance. What it doesn't tell me is whether this non-compliance is for something that's not integral to the safety of our patients, like fire or cardiac arrest understanding. So do you have that broken down?
So we do underneath that. So it was one of the things, for example, when CQC came, we had to break the down. So in the significant clinical risk ALS, and we had good percentages. It's in the more wider, probably more, should I say, corporate range in mandatory training. But they're all important, aren't they? And so we're absolutely drilling that down by department. The clinical directors have got the list of people that are non-compliant, and I'm expecting a detailed report next month.
Yeah, because I think that's really important, because when you start getting to that level, then you start affecting the working of the organisations and stuff. Thank you.
It was just, I just might as well pick it up here. Is just around the mental health patients, really. So both EDs have that problem, and there's a risk on the entry. What's different at the Royal is a little bit the numbers that the Royal get as opposed to the entry, but the mental health help that nurse. So from an entry perspective, we are looking at that and seeing if we could replicate it. The problem is assessment times have reduced the length of stay. It's beyond replacement, as you say, Tracy. So and when you don't have a dedicated spot for them, they do then sit in the ED, and that's not the ideal situation. So there's some changes, as alluded to earlier, with the movement of us to do So there is a possibility that we could develop a mental health hub, although there is some. I just want to pick that up now because it's a similar risk on entry. Thank you.
Okay, all good. Thank you, Natalie. We move on. And next.
Thank you, Chair. So I'm just going to go through some highlights and some I want to escalate. So first to say, in terms of the risks, we currently have 10 risks sitting at 12 and above on the entry risk register. That is the same number as last month, although there has been change in that risk that has been around radiopharmacy has now reduced because of the controls we put in place and the agreement to move the multi-vials. So that reduce hasn't disappeared, but the risk hasn't disappeared, but has reduced because of that control around multi-vials and the agreement we've had in the system. Another risk has increased, which is 8205, which is our finance income related risk, which I'll come back to. There's one sitting at 13 currently on the entry site, which is 6425, which is the ability to discharge patients in a timely way, and I'll come to that through my report. Before I just get into the risks, just want to close a couple of loops. So last month I reported, if you recall, a national shortage of a particular type of molybdenum TC99 generator. I did say at the time that was going to be time limited to 4 weeks. Thankfully, that has fallen out, and that risk is now reduced and disappeared off our. So I thought I should just report that back. The second thing I want to just bring to the attention is that if you have seen in the press that our March entry medical CQC report was published. And if you recall, it was from an inspection that was in March, so completely separate to the inspection that went on in October. Medicine, we didn't get that report until September. When we did get it, there was access-related problems, shall we say, to it, but we finally got that report, and it was published in earlier on this month. We look at our CQC action plan and our regulatory compliance every month in HMV. I think from that March related inspection, there was a couple of really key issues. One was staffing levels, and the second was our full capacity protocol and use reporting. The HMV had some assurance, and if you look at the IPR, you will see it as well, is that the nursing levels now have significantly increased, particularly RCNs and by day and night. So we took assurance that that particular concern raised by the CQC has been dealt with. We've also updated our full capacity protocol and communicated that widely. And in the second inspection in October, there was no concern raised on site. So we have got some reasonable assurance that that risk is being dealt with. There's some further risk, obviously, that we've heard back. We haven't had our formal report yet. That's still waited from the October inspection. But the verbal feedback and the written feedback we've now had it did raise some further actions for us, and most of those are in train and being dealt with as we move forward. So again, reasonable assurance that we are managing the feedback from the CQC. In terms of the key risks, I'm going to sort of split that into two things. Firstly, urgent care, and secondly, financial risks. There's 6 risks there, so 3 around urgent care. As I've already said, if you look at IPR and look at our right reports, we are seeing an interest for that double whammy in terms of our urgent care pressure. I think we are firmly now in winter mode in entry. That tends to happen around mid-November. So we are seeing, if you look at the IPR, a slight increase in patients being discharged, particularly if you've got no criteria to aside, and that's both P1 and P3. The actions there will sit firmly within the Mersey integrated discharge plan that we are working with our system partners. And as I said earlier, we're really trying to look at that TOC and how that TOC functions. We now have a dedicated group working on that, and we should be seeing some actions in the next week. We are hopeful that will make a difference. If not, then we will continue that conversation with our partners. Second is that the brokerage function now has moved from Mersey Care to the council, and we're hoping that will help with our P3 discharges as well. So there is actions in train that we're expecting to make a difference to our long lengths of stay. You'll also note, and there is a statistical difference on the light report in terms of the attendance, type 1 attendance at entry. Again, that is as expected. My concern is, as I alluded earlier, that we're now in the last week seeing increase in respiratory viruses, definitely in flu, probably in RSV. So that will be compounded, no doubt. That has then led us on to some pressures within the hospital, and I have opened some escalation beds on Ward 25. So that's linked to our winter plan. So they're already open and operational. In terms of dealing with that, we have just gone through and refreshed our own internal flow improvement plans. As I said earlier, we have moved our Sudoku. That allows us now to make some internal changes in the ED department just to improve flow within the department and allow us to get hopefully a space where we can offload ambulances in a more timely fashion. And again, if you look at the IPR, you will see the key deteriorating metrics in terms of VC are the time to ambulance handover, 60-minute delays. So that hopefully those changes will help mitigate that. As at the Royal, though, we can take some heart in that our time to triage remains above target and our time to treatment and safe commission 60 minutes remains above target. So the patients are being seen in it. In terms of the finances, there's obviously 3 risks associated with our financial position at Aintree. Month 7 actually saw a break-even. So our adverse variance of 10 million has not changed at the end of month 7. In terms of income, there was an overperformance of 1.64 million, which takes us to an overperformance year to date of 3.9 million in terms of income. And that includes pass-through drugs, and in particular within month, some of that was realignment of income related to advice and guidance that we had been doing at Aintree but not receiving. So that helped the position in month. And we achieved 99% of our weighted activity levels and our planned compared to 90%, which is one of the best positions for Aintree this year. In terms of pay, we were actually underspent this month by 0.45 million, although the majority of that was related to some realignment around pharmacy income we were expecting. And to take that out, we were overspent by 0.5 million. That is a month-on-month improvement in the run rate. If you go back 3 months, we were 1.2 million overspent. So we are seeing a gradual, sustained improvement in the run rate in terms of pay. Most of that has been driven by the improvements in special ops and the control on special ops. I see that it's at least a £2,000 per month improvements around special ops. So I think a lot of that's been driven by that. The adverse position is being driven in terms of pay overspend by the escalation ward, sadly, as I've already referenced, and sickness. As you can see, a little uptick on sickness on the IPR. So I think short-term sickness is driving some of that. The CIP position in month was 2.9 million delivered, which was the best month for Aintree this year, although still under our target of 3.1 billion. That takes us to a 15 million year-to-date transacted position against a 19.6 plan, so 4.6 million behind where it should be. The recurrent position is remains of concern, and we're taking some significant actions to try and deal with it, but we were 7 million recurrent. So we are going through some of our pay-related themes to can make recurrent, and we can see a way to improving that by 5.5 million. Some of the work we've done over the last month. So hopefully we'll see improvement in that. We're expecting an outturn position of about 24 million for CIP at Aintree currently as it stands. Pause there and take questions, Chair.
Thank you. For those that feeling a bit uncomfortable, the financial context explains why we can't afford to each on in the board.
Yeah, it's never usually cold at Aintree. So I just wanted to draw attention to page 205 and that I think commend the Aintree team for the nursing improvement. If you look at the last, since we started trying to resolve this problem in January 23, it's been a huge improvement, but that's exactly what we should expect to see. So we've now got really good levels of substantive fill rate and bank fill rate of nursing staff day and night. We've also then seen the numbers of HCA fill rate coming down to where it should be, rather than just throwing lots of HCAs into the mix because there wasn't enough training. That's a really good illustration of both getting the right staffing mix on the wards, but getting the pay under control at the same time. So that's been you can see that improvement over the last 5 or 6 months has been significant. So just thanked us for a long time at entry. That's delighted to say thanks.
And thanks for pointing out. And just really to add to that, was watch that very, very carefully. And our concerns was, will that have an impact on quality? And what you can see, if you look again at the IPR, there's been no change in those nursing quality metrics such as pressure ulcers or falls. And again, there was no mention of this when CQC came as well. So I think, from a staffing experience point of view, but also from a patient point of view, there's been no negative impact in that. So it's just much better management of the staff that we need. And again, I just want to reference David and his team as well, because it hasn't all been us. So David's team has been very helpful, but also Jen Taylor, our new Director of Nursing, has done, really gripped this for me and done a great job with it. So I should really pay some thanks to her too.
Thank you, David.
Chief Executive that was out, so it was the same point that I was going to make. But thank you for that. And I think it's really important to note that the point that Pete's made around policy and safety aspect, that we're monitoring that, but we're also one of 10 organisations that's national collaborative on the enhanced care for patients, and so we're taking our learning that we started a few months before the collaborative commenced to that national group to share that as well, and then we're going to be sharing that national learning within Cheshire and Merseyside.
Yes, please.
On the delayed discharges, you've got more local authorities to liaise with than necessarily NAT. Are all the issues the same across all 3 local authorities, or do they vary? And is there any joint working that they could pick up with the 3 local authorities to share good practice?
So you're correct. There's 3 local authorities. There's Liverpool, Sefton, and Knowsley. Roughly, Liverpool 40% of the patients, Sefton 40% of our patients, Knowsley 20%. That's a breakdown. Knowsley generally perform well in fairness. So there's less. There's a much better and lower delayed rate with the Knowsley patients. Liverpool and Sefton are much of a muchness, probably just a bit more pressure in Liverpool than Sefton. In terms of working jointly, we do that. Jan, I think that's part of the North Mersey Integrated Discharge Programme. That's why that was set up. There's much more to look at a hospital footprint than a police-based footprint. I think that was the intention of it. I always remind people in those meetings that it's not just Liverpool, it's also my Sefton patients that we need to and so the system is set up to assist. But yeah, we've got to work jointly across all 3. It does make it more complicated for staff. What we don't want is 3 different systems to discharge a patient. We want one system to discharge. We can't be thinking now you're Sefton or at Liverpool. So that's why looking at it on a hospital footprint is much more sensible.
Thanks, Joe. David.
I think Jan was looking at my question there.
Eyesight's not that good.
But it really is a concern. I mean, some great work going on at Aintree. Thank you very much for the report. But the IPR as a whole shows a number of patients with no criteria to reside going up. 330 last report, 383 this report. Rob gives us an insight into the jaw-dropping costs of treating these patients in inappropriate accommodation. So is there anything more that we can do, with this system-wide project that we hear about to try and get these patients moved to more appropriate accommodation?
So, I mean, I'll just pass to James. I think he probably wants to say what I was going to say, but I'll leave him to say it. But I just want to, you're absolutely right, just to make the connection between, if you look at, I reported a potential 24 million outturn in our terms of our CIP. The underperformance there, I think, largely sits with this problem for us. So there's 10 million with no criteria to reside reduction sitting at Aintree. That's the bit that I don't think something will achieve, which is absolutely linked to this point. And then the quality issues, I completely agree with you. And that's our value and patient time collaborative. And we're trying to weave that into everything that we do, because you can look at lots of data that shows now the longer you stay in appropriate hospital, the higher the risk and the higher the mortality actually. So I'll pass to James about maybe what else we can do. I think you're going to say what I did.
Well, I mean, I think the first thing to note is that we have, through our improvement plan, the levers to Though some of this obviously sits outside the organisation, however, the people who are involved do attend now our improvement board for our improvement plan. And I asked them this question this week because there's been some fairly sort of glacial shift on some of the key things that we all as a group said needed to happen. One of those was the transfer of the movement into the sort of bed brokerage into the council, which is the right place for it. Everyone's agreed with that. I think that's been supposed to happen for several months, but it's actually now happening this week. And I got confirmation of that yesterday. So that's good because that puts the right resources in to the right place for people to be able to do something a bit better than perhaps it's been before. The other one of those is the transfer care hub, which is where we're still a big outlier. And if you look at it, the average time it takes to get a P1 patient out, that's a patient who should just be able to go home or might need a very simple, so a good example, you know, a key safe putting on the door so that social care can get in or whatever it might be. Those should be really moving through that transfer of care hub in less than 24 hours. And here it's 6 days. That's owned and operated by Merseycare. We're all, again, that's not us shifting the blame to Merseycare, we're all working on this together. But we did sort of have the conversation this week about, I can't keep going back to a board meeting and saying, it's coming. When are we actually going to see a benefit from that? I think the transfer of care hub is the most contentious point because it wasn't compliant with national standards. So there was sort of, I think it was 7 key criteria that a transfer of care hub should have, and we didn't meet virtually any of them. The whole team have looked at what are the most important 4 and are putting all of those in, and we're nearing the point of those being implemented. So it almost feels like I asked the question myself the other day, exactly the same as probably what you're getting at here, David, which is we keep being told there's loads of stuff happening. When's it going to make a difference? So the reality was the brokerage movement was one big thing. These 4 elements of that top commencing is the other big thing, and that's happening in a matter of weeks. So my ask was, the next time I sit in front of you in a month's time, should I then expect to see some improved performance here? And the resounding answer I got was yes. So
fantastic. When you look at and you hear about patients who've stayed more than 100 days, that the average length of stay is 2 months beyond the expected date of discharge. So it's really.
Well, I had a conversation with the ICB about this the other day because the Newton diagnostic triggered all of this, didn't it? And took a look. And within that, we had a responsibility in that around our own management of long lengths of stay. And you can see from our metrics that we've improved that. And in terms of the time it takes to get a patient ready for discharge to discharge has come down considerably. So I think we've shown that we can make the improvements in the hospital part, but outside of hospital is more challenging. The one thing I would say is what the council are doing in terms of trying to resolve all this behavioural particularly, I think is the right approach. There's almost you could probably get a quicker win by moving all your resources to the back end and pulling people out of hospital. But what they really want to do is provide that upfront so that we're stopping people coming in the first place. And that will have a much bigger effect and a much better outcome for patients, but it's taking longer. So we sort of think they're doing the right thing, or we're confident of that, but it's taking longer to put in place because you've got to completely shift the way that you work to do that. So again, I'll stop now, but it's that thing of, we looked at the metrics and they were starting to improve. It's sometimes to pull out what the winter effect as well. But it feels to me like the system works better. We understand the data better. One can see whose responsibility things are now. There's some things about to happen. One's happened this week. The next 4 will be the next few weeks. I think then we'll know whether it works or not.
Look forward to seeing the data next week.
Yeah, me too.
Thank you. Can I just pick up, Jane, come back to the issue about ambulance handovers, and we already thought about the context of increasing pressures as we get into the period and so on, but the striking similarity on the line in the IPRs in the last 2 months of the Royal and at Paint, it's that if I read the chart correctly, the number of over 60-minute handovers is record level at Aintree in the last 600 and some 20 a day. Ambulances spending over an hour outside, and pretty much doubled at the Royal in 2 months. Is there some policy change or operating procedure change underneath that? Because the rate of increase is scary on all of that.
Yes.
We've said in the board before about the importance of being a good system partner. We expect that of others, and we need to be that ourselves. That's a lot of ambulance time off the road.
So just to be clear on that, what's not happened is suddenly that Luft has gone to the top of the ambulance handover table. Basically, the position, so Luft generally features fourth or fifth in Cheshire Mersey. I'm not going to name all the hospitals, but we're not at the top of that problem list. That list has just all escalated at exactly the same time, as has the rest of the Northwest. NWAS has had the second highest problem with ambulance turnaround in the country just this week, and reported delays of sort of 9 hours plus in certain hospitals. So it is unfortunately what we're seeing is just that whole winter pressures thing. It always happens fairly quickly, usually November time, where everything just goes up, and that's exactly what we've seen. So where we are is we're in the Northwest is generally one of the top 3 or 4 most pressured on urgent care, but better on all the other metrics when you go across the country. Cheshire Mersey particularly is challenged within that. But we're not standing out as the major issue as Luft. When you get beneath Luft, Aintree does stand out more so than the Royal, for reasons Pete's already explained. So it is just the pressure. It isn't a policy change or accounting change or anything else. The whole table's just gone upward in units.
5 out of time when I drove in this morning.
6 and I'm yeah.
Was it?
Yeah.
It's good to see we're getting live reports. That's safe.
One more eye, right? Absolutely right. And this, you know, you can see it in the IPL. That's why I referenced it. There's the bit that James talked about. Absolutely agree that there's 2 things I think we can do. One sits North Mersey programme, which is the ambulance conveyancing, because it's not all, you know, alternatives to ED. You know, we can't, you know, just because you call an ambulance, you don't necessarily have to always attend the ED. There's other alternatives, and we need to work with our NWAS colleagues on how we are doing so. I think there's a specific bit for Aintree as well, and that's the bit I've alluded to now. We've made some estate changes. Can we get people off the ambulances as quickly as possible who are ED, so that we can care for them there and get the ambulances back out on the road, because that is really key to the population. If you need an ambulance, it should be back out on the road. So we're doing some internal work in Aintree to see if we can deliver that. But there's the other side of that coin as well, which is making sure that alternatives to ED are always thought about, because, you know, in terms of when you come and to there's a better place to get your care, so you're trying to as well.
Thank you.
Yeah, and again, kind of bringing the day job in, we're doing a piece of work with NWAS at the moment on exactly that. So automated triage. Yeah. They recognise that actually a lot of what they're doing is taking patients to the wrong place relative to their health concern. Yeah. So we're looking at that, and I think there's a whole piece of work that we can put together, which is around that patient journey, using AI automation triage. But we're actively trialing that with them now, so maybe we can bring some. But yeah, it is.
So again, when we come to our strategy and partnerships committee, I think this is where we'll start to see some of the potential, because you saw with the endometriosis pathway earlier. It's one person, but that lady attended ED 5 times and ended up being stented each time, or having a bigger stent put in whilst waiting for a solution. I was responding to a lady yesterday who's stuck between Aintree and Walton, because she really needs to get her appointment at Walton, but in the meantime, every time she falls, they bring her through the front door of Aintree. So we come back to the point we made earlier about the diagnosis and treatment models that are different. We do know a lot of the people who are coming through that front door is they're delayed in getting treatments elsewhere, and if we could resolve those bits, it has a positive impact on urgent care. Still won't solve a problem of trying to put 100% of people through 75% of the beds, which is our biggest issue, and that is the national biggest issue. Get both ends of that focus. That's a chance that we've had in previous year.
Thank you, Peter.
Thank you.
Report. Let's move on. Jenny.
So Liverpool Women's Hospital Management Board report. It was our first hospital management board. It went well, really good engagement. So that will go from strength to strength.
There were 2 limited assurance areas, which I will come to shortly. If I start with the high risks, there are 5 high risks coming through. I'm keeping under review in the context of the new group arrangements with the sites in terms of consistency and calibration. The risks cover 4 food areas. Anaesthetic cover, we have work ongoing with the Luft sites to make that more robust and aiming to have that fully in place by April 25. It is a key focus of our improvement plan. I think Tim will pick up some of that when he gives his improvement plan update shortly. We are also aware of gaps in medicines management and pharmacy staffing following a review by our chief pharmacist. We are currently developing an action plan in relation to that, which is likely again to form part of our improvement plan next year, or at least follow improvement plan methodology. And that business case is underway with the Clinical Support Services Division. And the final risk we have on the register is around neonates. Many will be aware of the long-standing issues we have with neonatal surgery being held over at Alderhay, and obviously the neonatal unit being at the Women's. There is extensive work going on over at Alderhay at the moment in terms of building some more space over there. But as it stands, we have the neonatal provision split over 2 sites. To address that, we set up the Liverpool Neonatal Partnership with Alderhay, which is again going from strength to strength. We are going to be reviewing that with Alderhay next month and their leadership team to see how we need to continue to take that forward. But work is ongoing with that partnership, which is working well. If I move on to, there was a question in relation to the neonatal risk itself, and the question was from a member of the public around the use of telemeds between Liverpool Women's and Alderhay, and is there consideration of this between Liverpool Women's and Luft? So yes, the use of telemeds was introduced with Alderhay and the Women's during COVID to help. Obviously, we had to minimise some of the travel between sites. That's been really good, and I know that the neonatal partnership are looking at that at the moment in terms of how they can take that forwards. That's one of the pieces of work they're reviewing. There was some use during COVID at Luft during that period as well. And I think it's something that we just need to explore further across those. So Nat and Pete can pick that up around what opportunities we've got going forward for the adults as well. I should also note there is no finance risk specifically for Liverpool Women's on this risk register, and that's because it's on the BAF. So we'll just, again, when we think about calibration, it is on our BAF. It's one of our key risks for Liverpool Women as a trust. So if I move on then to the financial position itself, we covered month 6 and month 7 at the Hospital Management Board report because the timing of the meetings as we went into the new structure. We wanted to make sure we didn't drop a month and we wanted to make sure that both months got scrutiny. Rob will pick up the overall position, I'm sure, in his report. But just to note some key issues, at month 6, the Trust did receive some additional income on a non-recurrent basis to the tune of £16.9 million, and that's reduced the amount of planned deficit at the Women's, and it also means that any further cash support required for the rest of the year would not be required if all goes to plan. So you'll recall that no, we did need to draw down central funding for cash support, but this extra money has now mitigated that for the rest of the year, but it is non-recurrent, which means it's a one-off position. Overall, both month 6 and month 7 were slightly ahead of plan in line with our revised forecast. Just to flag as well that we know that whilst we are on plan to hit our forecast and revised plan, there is an element of non-recurrent CIP within that in terms of our delivery of the CIP position, and that will cause issues moving into 25-26. On the financial position, there was a question came in through public yesterday around the income in relation to the Community Diagnostic Centre. I imagine that those who followed Liverpool Women's and the Community Diagnostic Centre, the first few years of that were precarious financially, I think it's fair to say, in terms of some of the commissioning and getting it off the ground. And it did prove slightly problematic for Liverpool Women's financial position in the early days. But just to be clear on the position in this report, the income hasn't fallen, but it is behind plan at month 7. It is overall due to
hit target or just be below by about £500,000, so £0.2 million full year. But I think what's important to note, it's more around the phasing of the income rather than an actual drop in income, because actually the income for the CDC in this financial year is higher than it was in the previous year. We just took a bit longer to get off the ground with some of the scans. So overall, not a concern or an issue for at Liverpool Women's. So as I mentioned, there were two areas of limited assurance. One was in relation to the clinical effectiveness group, and that's simply administrative. We didn't have the IPR at that meeting in time at that first meeting, and we are addressing that. So whilst there were no issues flagged, particularly or concerns flagged, we just didn't take assurance because they didn't have the IPR in front of them. We've got plans in place to ensure that's addressed for next month and that runs smoothly. We also took limited assurance from the internal update that was presented to the board, and that was presented to the hospital management board with limited assurance, and that was as a result of the number of open recommendations, some of which were old and some of which were high risk. So whilst that didn't necessarily feel particularly out of kilter with prior years, we did accept that actually if it stayed as it was, it could cause an issue for the head of internal audit opinion. We have historically had substantial assurance through those head of internal audit opinions from a similar position, but we weren't assured that they were being addressed. Delighted to say that we reviewed that again as our hospital leadership team yesterday, and that has improved. 25% of the open actions have been closed, and there's a refocus on those old and high risk. So I think as we head towards the year end, that level of assurance will increase through that. Sarah, you asked around the number of stillbirths. It wasn't particularly, well, it wasn't escalated into the hospital management board because it wasn't a particularly sort of statistically significant variation. We do see ups and downs within the month, so it wasn't discussed at the board. And I know we're going to talk about SPCs and how some of that works, but hopefully you'll know and you'll see, particularly coming through the maternity incentive report, that there are many things in place where we do review and keep an eye on stillbirths. So it wasn't an escalation, but we obviously keep an eye on that.
My concern though is statistically month on month there isn't a variance, but if you look at although statistically month on month there isn't a variance, for the last 3 months we've been at 10, 8 and 8 versus a prior quarter of 4. So that is a huge statistical variance over a quarter.
It's not using SPC now. Okay. So I think this is somewhat we want to cover next week. There's only one statistical variance in that entire run, and it was about 9 months ago when there was a point outside. So that's just noise rather than a signal using SPC. So this is something we'll cover next week.
But just for your assurance, when
we've gone into a bit more scrutiny quality with that difference.
It would, but my concern on that is comparing quarters isn't giving the right answer. That would be misplaced scrutiny. We're not careful, so we want to use the SPC rules to make sure we're looking at something that's statistically relevant rather than just random variation, which is what that is.
Like you, I feel sometimes there's things that require an explanation because they don't look and feel right, only to be said, well, in the structure of the making data count, it doesn't merit further explanation. So there's still a bit of work for us to do to reconcile these things.
I think so. I think so. You know, obviously coming from the history that we've got through policy committee and the level of detail that we would go through. My triangulation for me is that bit around, as I say, if we look at sort of the perinatal mortality tools and the way that stillbirths are tracked and monitored through the organisation, that gives me assurance around the processes and the way that we're looking at things, and you'll see that we're on target in terms of, as I say, using the Liz as an example, in terms of achieving those standards and the rigour that's going in from that point of view. But yeah. So just quickly on the waiting list. So we are seeing a reduction in the size of the waiting list, but still too high. We've still got lots of ladies waiting to access appointments. We've seen about a 20% decrease this year, but as I say, still too high. And whilst we are seeing a reduction in the longest wait, there's a significant issue and backlog. That's a challenge across Guinea nationally, and we are supporting some of the trusts with their longest waiters as well. Just picking up on 65 plus waiters, we've got 5. That's through patient choice and complexity, but we are aiming to get that down. Just to note as well that we did approve the terms of reference, which we approved here today. And other than that, I'll pause and take questions.
Thank you. Personal.
Thank you. Jenny, just around the performance bit, it talks about 3rd and 4th degree tears and that it's continually achieving each month with current incidence totaling 2.15. So I can see it is 2.15 this month, but it's not been continually performing, and it has generated a thematic review around 3rd and 4th degree tears. So I just wonder if perhaps the board may want to be more aware of that next month when you come back, because it has been off since December 23. So if we could have a look at that. Now, it might maintain that downward trend, which will be grand, but there is some issues that came out in that thematic review.
They did, yes. Apologies, Jackie. I meant to pick that up. That's been a typo in the report. So you're right. The 2.15% is correct, but it's not a continuous piece. It's an improvement on what it has been before as a result of the work that's done. So yeah, we can bring something back here.
Any other points? Yes, Tracy.
Yes, thank you, Jennifer. Particularly around the internal audit plan and the fact that that's actually sort of limited assurance, and that's been made that in this report. I think at audit committee in October we were concerned about one particular audit around the quality spot checks. So I know normally would have referred that to our quality committee. That's now not happening. So it's just really just hearing a bit that actually those actions are being closed quite quickly, and specifically because I think we were concerned about that. And then also it mentions these 5 audits that were supposed to start in Q3, which you're behind. I suppose that's with the changeover with everything, but we do need to get back on track, don't we, so that those get completed, because that will be significantly behind the plan if we don't get those done and reported through to audit committee at the end of January.
So the quality spot check do form part of those open actions, and formed part of the discussion we had yesterday around the prioritisation. They were the areas. There was a lot of work already needed to just consider evidence in now. So the director of nursing on the site is really pushing to get those closed actions and evidence through those. And yeah, I agree around the pressure around the audits in the final quarter. We've just got to keep our focus on that, get that through, to get that completed. I'm not overly anxious at the moment.
So really useful to hear about the quality spot check actions that they closed down here in December, because I think that's quite important to know how we're progressing with that, and that's got visibility.
Daniel August.
So just 2 issues. So the quality spot checks are on the agenda for the quality and safety group that's chaired by Di Brown, and that will report through each month until they're all completed. In relation to the Q3 audit plans on the programme, all of them we've now got confirmed with field work status, but they're actively being done. We expect 4 of them to be completed and reported to the audit committee in January, with the final one probably due to be completed in February, which will come to the March committee. We've already started work on the Q4 parts of the audit programme. 2 of those are already in field work status, which is slightly ahead of schedule. So I think the work that Jenny and the team have done have actually probably put us in a very good position to get both the audit programme delivered within the agreed timeline, but also reducing the number of open recommendations. Massive progress in the last few weeks by everyone involved. And again, they're all being discussed at the relevant hospital leadership team groups and owned by divisions and individuals as well.
Daniel, very clear. Do you want to come back on that, Tracy?
No, that's fine.
Any other questions for Jack? Okay, thank you. Now, I advertised a break at 11:30, but I'm going to complete the round of site updates with laboratories and then broaden, and then we'll break and pick up the financing group. So, last please, Rob.
Okay, thanks, David. So, from our management board held meeting, happy to say no risks of 12 or above, but a couple of items I would like to draw out for attention. First item was risk 8116 relating to staffing in microbiology and the potential for industrial action highlighted by our colleagues. We have initiated a task and finish group to report back through the hospital management board, looking at staffing levels, comparing those to peers, and also working with Cheshire and Merseyside network colleagues, because I think one of the issues continues to be around recruitment and retention that we do not pay, but others do. Previously reported that would be just over a £750,000 bill for us. So we're bringing that up with the network to highlight, but working with unions to hopefully resolve the issue. Second risk to highlight, which we raised from a 10 to an 11, relates to Clinicist WinPath, which supports our transfusion service at Aintree. We are moving over to the new system that's currently run across Royal, but there will be 5 days where the old system is unsupported, because the implementation will be on the 6th of January. So we've highlighted that as a risk. Thought that was a lower risk than trying to implement this over the Christmas period, and we've got a full backup plan and business continuity support in place and aware. So we have to recognise the risk, particularly in light of cyber attacks that have happened across the water. The third item, just to know, is risk 8559. This relates to our specialist ophthalmic pathology service. We have done a business case and a review based on the increased demand of over 20% over the past couple of years, and we put forward a business case to the network for more support. We await a response, but we're certainly making that case strongly. I mentioned the task and finish group around microbiology. There are 2 other groups we've set up, again trying to push the partnership, working with our staff side colleagues. They are around the chemistry IT system and training we are providing around that. There's some noise, so we're trying to work together to ensure that that's all appropriate. And the histology working environment, which relates to ventilation, which again we've done loads of work on, but there still remains some disquiet. So we're working to try and understand exactly what that is and get to the course. In terms of performance, histology cancer performance remains a challenge. We consistently call that out. What I am pleased to say is that 2 consultants are starting with us. New consultants are starting with us from December, and that should start to show an improvement in January data. Finances, just to note that we are ahead of plan at month 5, £500,000 better than plan, and also ahead of our CIP plan. The forecast is hit the year-end position, albeit that there's still some work to do on changing our CIP to recurring. So we're working on that over the next months, and intend to deliver that plan currently. Just to note, we had the UK Accreditation Service, UCAS, assess us around infection and immunity. The assessment was very complimentary, and accreditation is expected. And I think they are the key things I want to pull out.
Thank you, Rob. Any issues anyone wishes to pick up on that risk report? Tom and then Jackie.
Chair. So it's good to hear about the increased staff in histopathology and the issues around ophthalmic pathology. But what's missing from this data is an indication of what the impact on patient care of those delays in histology are. Are patient care pathways being delayed? Are people being kept in hospital the approach too long as we're waiting for results that may affect our future care? What's the knock-on effect?
Well, that has come up at our management board, and John Brennan now is our interim medical director and sits on the board. And John provides reassurance that there is no harm to patients from that, albeit that clearly it's not the target. We're not meeting the target at this point in time, but we can have some more on that going forward with that.
So could I just ask about the finance side of it? So it's great news where LCL is up to. I just wondered, is there any stretch that can be put in there to help support the rest of the organisation?
Though we were friends. There is, we are ahead of plan. Now, the flip side.
Here we go. Here we go.
The flip side of that is that we're also ahead, which is unusual actually, across all the sites. We're also ahead on pay. And obviously we're having this discussion with our colleague in microbiology about staffing levels there. So yes, we will certainly try and overachieve, continue that performance, but there is a recognition that we may have to invest in staff depending on the condition.
Okay, I'm sure having a conversation with yourself in your two capacities will resolve the issue.
I'll have a quiet word.
Any other point? Thank you. So we conclude the site update. Now, as James reported last time with an item. So, I'm sorry. As James reported last time, the leadership arrangement for the Broad Green is switching to Natalie participation of further group moves with our chest. So whereas previously I turned to Heather this update today, I turned to Natalie. Is that okay? Very nicely done.
This is now the highlight of my working week with Broad Green. So there was only one risk, there were 12 to know, which was in relation to dermatology. So this was around skin cancer performance. So due to some vacancies and sickness in the medical team, we created a bit of a backlog and an issue with skin cancer performance. The team have put some temporary support in place, and we are in a much improved position. So this week now we are booking our referrals in at 7 days for first appointment. So we are well within the standard again. And the team have presented me with a plan which will maintain that when the temporary support ends at the week. So we will be downgrading that risk now, and we'll just be monitoring performance as we do through our normal ops groups on a weekly basis. Finances for Broad Green, that we are on plan and break even. Broad Green are forecasting to achieve the CIP for the year. The issue is most of it was non-recurrent. We've done an exercise last week that I've been through with the hospital leadership team, and we've even presented this week to Rob that we believe we can flip a significant amount of those schemes recurrently before the end of the year. So we're just going to work through that over the coming weeks. The only two things I would raise at Broad Green, so a really positive IPR for Broad Green. There's just one metric which was significant, is the sickness absence increase at Broad Green is at 7.6%. That is the highest across all the sites currently. We did discuss that in detail at Hospital Management Board, and we are meeting on Monday to have a look at a bit of a deep dive into that and what we can do to support the staff there around their sickness absence. And then the final one was just clinical teams, clinical leads did raise around, I suppose, the ongoing triangulation around the vacancy controls and some concerns that they were raising around essentially the lack of admin support from the clinical teams and what impact that could have. So we did have a detailed discussion. We are triangulating that, and we think that is manageable currently. But I think it was good to note that we are having to keep a really close eye on what we're doing around the vacancies and any unintended consequences that may have to clinical teams. Raise it.
Yeah, just on skin cancer and dermatology in particular, every time I go to a conference, I find us there presenting about AI and skin cancer and telling us it's all this brilliant stuff to reduce pathways, yet it still seems a pressure. Not asking to answer this now, but it would be useful to understand how much are we leveraging that across the whole of dermatology versus it being a bit of a project in a small amount of dermatology, because it seems like a really obvious way to improve things.
I can answer it now if you want. So we've been trialling that, I think, as a pilot in part of the Cancer Alliance work with human physics. I think it's about expanding that. I think what I would like to do, I think we need a full demand and capacity analysis in dermatology of how we manage it. And we had a detailed discussion. I've managed dermatology previously, and we've made an awful lot more prescribing pharmacists. A lot of it is around dermatology, and I feel it's quite limited. So we talked about in our improvement plan for next year to grow green, we're going to do a bit of a focus on dermatology, because I think there's an awful lot and a really engaged clinical team who are
good team with opportunity.
Yeah.
I think the other thing that we're also arranging, I know you may see the presentation again, so we're asking them to come and present it to the board and talk very much about some of the plans to expand it from its current pilot area and the speed in which that expansion can take place.
Jeffrey, please.
Just on that, you may know the answer to this question. Are there any GPs that have interest on dermatology in the Liverpool area? Because when I was at St Helens CCG, we had two very good doctors, GPs, who really deflected a lot of work away from the acute by doing work in the community.
We've asked previously, but to no avail. But you know, the argument, and I think there was one working in quite a deprived general practice who was struggling to recruit GPs, so wouldn't give up no time to expand his expertise on GPSI. So there may be some, but the limitations have been capacity in general practice.
The place.
In relation to the absence of broad green, it's a recurring theme over the couple of years that I was looking after the site. And when we've looked at that, there's quite a lot of detail that we can share with you that's already been done around the demographic. But there's real links with flexible working and demographic workforce. Was the idea really to start bringing down absence, using it in a way to deal with life.
Okay, thank you. Thank you for all the presenters tonight. Picture of where we're at, and the challenges and the progress. So we'll take a break now. I'm running late in the management of the meeting, so we can take a 10-minute break and we'll come back to do the financial overview and the rest of the stuff. Thank you.
Right, please. So the group report you can see in front of you. And you'll see that point out that obviously as two statutory organisations, we are still producing two reports for Liverpool Women's and for Luft. And in terms of, so you'll see those separately. And what we've done is then combined the two, added the two numbers together just as an overview. It's not a full consolidation because in an accounting sense, but we've added the two for the overall picture, given the commentary on top of that. So in terms of Liverpool Women's, as Jenny has mentioned, what you can see is that the trust is ahead at month 7 of plan. The trust is ahead at month 7 and is forecasting to hit plan at the end of the year. The overperformance month 7 will be pared back, partly due to the investment made at the start of the year that is coming on stream during the last part of the year and in the final quarter. The CIP is also ahead, but also has that issue, as mentioned, about the non-current. So at the moment, 2 million out of the projected 5.9 is noted as recurrent, but we're working on that together. So the aim is to increase that percentage to the overall position. In terms of Luft, you can see that the trust is 7 million behind plan, with a deficit of 60.2 million versus a plan at month 7 of 53.2 million. Income continues to be over plan, and it is impacted by pass-through drugs as well. So over £9 million worth of drugs ahead of plan we get the income for, but is also through our non-pay line. And our overall challenge remains around pay as at Luft for reasons for that. In terms of CIP, you can see that we are achieved 44 million, which is fabulous. Year to date, the highest we've ever done, and just under, half of that is recurrent. Plan though is extreme, with the 114.6 including the system stretch of 15 million. And David, you referred earlier to the comment in the corporate risk section. What that actually was referring to was the gap to delivery. So it was the 44 million versus the 114.6. But what is not in that number as of yet are the two stretch targets for the system stretch from Luft and Liverpool Women, both at 3.8 million. So we incorporated that, and basically that was a gap to delivery as opposed to a risk. In terms of overall context now for the group, so if we add the two numbers together at month 7, we are 6.1 away from our combined plan, and for the forecast remains to hit our year-end, official forecast remains to hit our year-end position of 44.6 million combined by the end of the year, although there are some risks inbuilt in that I'll talk about in a second. Just to take a little step back and put in some context as well, in terms of the overall financial position remains challenging across the patch. So in Cheshire and Merseyside, there's a month 7, there's an overall deficit of 113 million, which is 51.5 million worse than plan. So that reads across to our 7 million in Luft and our overperformance in Liverpool Women's. So in that context, we certainly are comparable with other organisations in a really challenging environment. Noting in terms of overall performance that there are in-year pressures that have hit both trusts. At Luft, we had strike earlier in the year, and you'll recall that whilst we received some funding, 1.1 million, there's £2 million that remains unfunded, and there's no real prospect of receiving that. So that remains a pressure. In terms of pay awards, the pay awards were received and put into month 7, and there is overall pressure of 4.3 million across the group, so which is 3.5 million for Luft and 0.8 for Liverpool Women's. We continue to have discussions with the system team who are representing that to NHS, and again that's not a unique position for either ourselves, the system, or the region. I've called out the operational pressure because I think it's worthwhile noting just how much resources we are utilising for the no medical criteria to reside patients. Around about 375 patients at any one time during month 7, which equates to, again, approximately 30 wards worth of resource, which again is about £45 million worth of resource. Now, it's impossible that you'd ever get that position to zero, but that continues to be a major focus for ourselves and working with the ICB team to reduce that, as we talked about. There's about 12 million of CIP within our books that remains high risk associated with that issue. I've also called out the fact that we continue to have conversations, and a letter is going from the ICB to NHSE in the next days, again representing that we've not been funded for this year for the new Royal. So that remains an issue we are pushing on. The CIP, again, I call out here. So we have a combined total, as mentioned, of £47.8 million, 44 million achieved in Luft and 3.8 in Liverpool Women's, and the additional stretch of 15 million. As at month 7, we transacted 2.7, that additional stretch. That's held in our books, but 11.2 million is being delivered through other organisations. So 2.7 was transacted at month 7. Whilst we've identified the schemes and we're confident of receiving that, we obviously can't put that in our tracker at this point until transacted. So that's something that remains an ongoing item I'll update the board on. In terms of the overall risk, you'll recall that we had an unmitigated risk of £14.8 million. In adding on top of that, the unfunded or underfunded pay award of £3.5 million takes us to a position of £18.3 million unmitigated risk as at month 7 that we're reporting in our finance report. Final point to note, a lot of the work and the structural issues that we have and have had over the last years, we're hoping to start to address through some of the last work. So working with obviously Liverpool Women's, ourselves, Swarton Centre and Rich, they're the 5 of us. We've commenced the work on a acting as one financial framework and the development of a financial sustainability plan. PwC are supporting us on that. 5 work streams within that, with 2 representatives from each organisation got together yesterday, supported by PwC. It was a positive meeting, and we'll obviously be reporting on that through the joint committee. In terms of this plan, what we do know is it's not going to be any easier from all the national rhetoric that we've had. The detailed operating framework is not out yet. It usually comes out on sometime around Christmas Eve. I don't expect it to be any different. So we'll keep abreast of that. However, we are individually continuing to develop our plans in advance. Happy to take any questions.
Thank you. Which question? Thanks, Rob. Really helped to have the no criteria to resign. So it's eye-watering, but it's really helpful to have it. I'm still concerned about both this presentation and the reality of pay. So on this basis, by the end of this year, we're 29 million over budget on pay. start figure, say we've got 600 people that we don't need or whatever. And obviously a lot of that is connected to the contract income, the operating income, but it's not presented in that way. It's presented as just a massive overspend and a deteriorating in-year position. It just doesn't seem to me to sit alongside the GRIP narrative that we're trying to present. So is that a different way of presenting that gets it closer to the real position? And then that will also enable us to say, so what is the real pay challenge rather than the challenge that's, I can't believe that it's a £29 million unmitigated challenge.
No, well, so I think you're right. We can look to enhance the pay analysis. I think the issue, and it is some of it is linked to no criteria to decide. The 12 million that we had in was all pay, so that does impact. Where we've got overruns, for example, in escalated corridors or staffed corridors, again, that's all coming through in pay. So there is an element where of overperformance, particularly around ERF, where we're doing more activity, and there's absolutely a pay element to that. We assess that, as I mentioned last time, in outpatients, there's around about a 30% cost impact. In a elective care, it's about 70% cost impact on the case. So we can draw that out more, Mike. But I think the reality is that at the moment, and I think you've mentioned this before, in fact, we are paid for less beds than we have open beds.
Yeah, thanks for the report, Rob. Very clear. I just wondered, you mentioned in there that there's the ongoing work with PwC. I know it's early stages yet, but is that giving you hope that we may be able to find some additional funds there?
Well, I think it's at the commencement stage. There are 3 projects. One around productivity that Beth's leading up into, around workforce, medical staffing and establishment that Heather's overseeing. I think last week was the first week in earnest of getting to grips with what is the plan. Am I confident? The return on investment is projected at 5 to 1. So that is a significant amount. Against the investment, we're going to have regular milestones. There's a weekly report that goes back to execs, and so I think I'll be more in a better position to feedback next time. There is a contingent element as part of the contract as well. So if it does not deliver, PwC will also lose money from. So I think it's too early for me to give you a confidence level, but unless the SROs want to. But I think by next week we should have clearer milestones.
Thank you. Heather, then Jeffrey.
Just in follow up, the work that we've been doing for a year already on medical work. What we're seeing is it's not CIP necessarily that we're going to benefit from, it's cost avoidance. And what we're seeing is it's a long-term burn. It's like a 2-year project, really. So yes, there is optimism in the numbers that they're looking at, but actually it won't be a quick win this year. It's more likely to be 25, 26, 26, 27 through job planning and linking the work that I'm doing around establishment with the work the Beth's doing around, activity and coordinating that. So they're not quick wins, David, but we're seeing some optimism from the numbers.
Jeffrey, please.
Really about the Mike's point, which I share his concern. And Rob mentioned the ERF is sort of adding to the paper. What extent is that being funded through agency work, and to what extent by bank? So are we adding to our pressures by using an excess use of agents?
So one of the weekly pleasures that we have is a financial incident command centre meeting at 8:15 every Tuesday. So James gets invited to that virtual meeting. One of the major focuses there, Jeffrey, is pay banking agency spend. And I think, as James alluded to before, what you see is that our position absolutely is on a downward trend, and has been for the past 3 months at least, but basically from the first quarter of this year. And I think that's credited to the strict controls we have in place, to the roster controls we have in place, and we are being put forward as an exemplar. So agency, for example, is eliminated in all admin and clerical position, but there is some still within clerical workforce. As with bank, when you can't fill a shift, we are having to rely on bank, and that's a common theme. But we are as an exemplar, and it is on a reducing trend.
Just to follow on from that, because we've seen the national press about some of the charges on clinical staff working in agents, quite astronomical. But nonetheless, for your control, we've still got the rising pay bill. So, what's the solution?
Well, I think ultimately, and this is a challenge for us, we had said that overall the workforce needs to shrink, and we want to use technology and shrink in that way. Our first challenge was to reduce banking agency because you save on the premium, and part of the solution was moving from banking agency into substantive posts. Obviously, whilst we've got other issues that, for example, no criteria reside, like that's the theme, where we need to service the organisation with 4 wards, escalated staff wards caring for no criteria to reside patients, then our staff bill and our WTEs will continue to be high. But we've got to focus on currently on our vacancy only approving as a guideline 20% of vacancies as they come up for admin and clerical, and looking to even reduce for estates and facilities a 50% rate, and considering clinical post carefully on every post that's put forward. So we are looking to reduce it overall, but at the moment the flip has been actually from banking agency into substantive. Also, if you look at the pay bill, obviously there is a pay award that came through in 70 that actually, the overall spend increases because of that.
Last point, just to follow on James, really, the non-criteria reside, just increasing your pay bill. At the start of this year, place directors were given a target by grade in terms of reducing non-criteria reside. How's that gone?
It hasn't.
The worst accountability.
A question for the ICB board rather than this one. But it's a valid point. So the trajectories were set and were missed, and the cost remains within the provider.
I think I knew the answer, but
just to give some so from I know it's still more than we need it to be, but from month 1 to 7 last year compared to this year, we're spending £6 million. We've spent £6 million less on bank and agency. Of the majority of that is. And then when I've just looked at the WTE growth that we report on a weekly basis or a bi-weekly basis, we actually went up 44 whole-time equivalents. 60 of those were GP in. So actually we've seen a decrease. What we are seeing though is an imbalance in. It's really frustrating because we can see all the posts that are being held and all the posts that are being taken out recurrently that we're overseeing as executives in our own portfolios. But because of the pressures on the wards, it doesn't show in our national figure. So Rob and I were talking about how do we show this, a bit like your question, Mike, how do we show all the work that's going on in grip and control when actually the headcount is being pushed from different sources that we're holding that we can't stop.
Natalie.
Just to answer Jeffrey on the question around the ERS. So this was the big issue at the beginning of the year. We were using the agency, we were using enhanced rates. At the end of Q1, a lot of that ceased unless it related, as we said, to a critical patient safety or cancer issue. And we've seen that benefit. There are some specialties that are still having to use internal bank, etc., to get the hours. So gastroenterology, we touched on, and my risk was one of the risks, and urology. Now, what we're doing at site is they are putting forward business cases which will reduce the cost of doing that, about expanding substantive staff, but we build it at a lower cost base than we're currently providing it. So at site, under my financial governance framework, I'm tracking those projects weekly, and that'll be coming through in future months. So we absolutely are on it at a specialty level. And I think the other thing just to notice, this isn't necessarily, Mike, for the forecast position, the 29 million is not necessarily that the run rate is not improving. The CIP that's coming in future months off, it's profiled against the pay. So it's, some of it is actually, like our Royal report, is related to the fact we haven't got the full CIP plan to get to the 40 million, and that's reflecting that pay, not that the controls aren't having an effect on the bank of agency and temporary staffing. It's the CIP underachievement.
I think to see improvement. The difficulty with this, of course, it's a lot of non-recurrent funding and in the position as well, and we're the deficit plan. Actually, the underlying position presumably is worse than that going forward, because of non-recurrent elements within that, and also the CIP. You know, I think you said for the left half of that has been managed, achieved currently. I don't know how that translates into a full year effect going forward, whether that's actually slightly less than that 22 million. Those are sizable figures, aren't they? And as any savings are to get into balance, that largest proportion is going to be pay. That's the problem we've got. All we can do is to try and track actually we're moving in the right direction, seeing that workforce and those figures are coming down really. And then there's that risk, isn't there, to forecast to year end. You know, those are quite large figures, aren't they, to be uncertain of as you're going through to year end for this year, really. So you'd want to know normally by Christmas, you know, where you're coming in. It sounds as if some of those things we won't necessarily know until the new year. So that must be a problem.
Yes, please.
Yeah.
Yeah, well, absolutely. I mean, we have highlighted to the ICB our unmitigated risk position. Clearly, there obviously remains pressure on us to reduce that further. Some of the PwC work, for example. But again, going into winter with these pressures, not looking for excuses, we know that there'll be more pressures coming our way with our continued focus on reducing the workforce if at all possible. One thing to give some reassurance on, we are now going through every post where we have taken a vacancy non-recurrently and seeing really challenging, can we take that recurrently, Tracy? So obviously we don't want to store up a further problem for ourselves going into next year, and we had a good session on that this week for a lot of those posts.
Beth.
Thank you. I just also wanted to report on national focus, given the financial context, is on making sure we're most efficient and productive as possible. In the October figures, it's showing that we have been reporting the highest utilisation in theatres, and also for the number of patients we've put through those theatres. But also to read across to David and your question about PwC, We're certainly embracing the team as an additional resource to our team, so taking a different approach maybe than last time, and the return on investment that Rob has just referred to, making sure that we keep very close to the deliverables week on week, and where we're not seeing perhaps that return on investment that we're expecting is to change the brief and change that in real time. And so we're keeping close to that. Just wanted to speak from an SRO point.
Okay, thank you. All right. Yes.
So we'll get into work section obviously in the part two, just around where all this is headed. But the fundamental issue for us is that if you look at all of the metrics together, productivity is up. We're doing better in terms of utilisation in outpatients and theatres than we were, and bringing more money in through that route. Talking obviously about Luff now, because the women's is pretty stable, although there is the non-recurrent issues still that we've got to deal with there. So that's obviously significantly better. We're seeing really impressive reductions in the use of banking agency, lower costs. We're going to end up with a higher recurrent CIP than we've probably ever done before. It'll be in the 5 to 10% region, different by site. And we're further away than we were last year, essentially, under this already. And this is all coming back to the same sort of set of issues where Rob started. So there's a letter on my laptop here that's going to the, thankfully now from the ICB to the national team to say it is not a sufficient response to say, sorry, there's no money for the cost of the new hospital for a third year. And at least now the ICB have put their name to that in a sense that, look, this isn't going to come from within a Cheshire and Merseyside allocation. There's a 42 million recurrent ask there that's not been met. And if you profile the new hospital money, had it been adequately funded into the last few years, you don't start with a position where you have to keep adding 10 million here and 15 million there of hopeful additions, some of them non-recurrent, and then come back into the same cycle. So we'll go through later what some of the potential rabbits in hats might be to resolve that gap. But that's the fundamental issue for us, is that we're still in this cycle of managing a pressure that's bigger than 4 years of CIP in most organisations just in one go. And so that has to get resolved. So we will come on to some of that in part two, because I feel that otherwise every year it's going to be the same conversation, because it's a routine 5% CIP in this organisation and control the costs. I think it's probably shown we can't do that, which is the usual ask. But once you start getting to 10, 12% and loads of non-recurrent top-up items just to get you to the end of the year, it's going to be a perennial problem. So Bob will take us through some of those options, potential issues later. But the only reason to be cheerful, and there is only one, is from a control environment point of view, spend, bank, agency, long-term locums, all the rest of it. We are dealing with that to a granular detail of names and dates, which a year ago the trust could have said we have that level of confidence that those things were being done. And it's not just our confidence, PwC concur with that, ICB concur with that. But there's something wrong if you get into that level of grip, you're still not going to get to where you need to get.
We'll talk more about it later in the day. I think that there are, James has said, old systems in. Start to see some effect in the numbers. At the end of the day, this is a result game. However beautiful the build-up play is, if we don't get to where we said we get, we will be in trouble. There are three. I don't need to deal with them now, Rob. Yeah. But three for avoidance of doubt, things that'd be handy to come through. An excellent one is in the Royal Investor's report on the finance page. It says the payroll walls have been fully budgeted and funded, but elsewhere we say, yeah, so can we just have clarity on where the costs are, what the budgets are like, and who's carrying the risk on that? On the pass-through costs, which you referred to, the income's in one line, expense another. Can we say if the costs are fully covered with the income line? Then also, I understand why you combine the numbers in terms of a bit of overview presentation, but the implication on that can be that there's somehow brokerage or support going from one position to another. So just an absolute confirmation that the two statutory improvement plan, please.
Thank you, Chair. And I'll keep this as brief as I can do because much of the item has been trailed in previous updates. Just on the structure of the report to start with, very similar to the IPR. At the moment, this is an aggregation of both improvement plans, which we will continue until the end of this financial year. From April next year, we're going to simplify the position by having site-based improvement plans that will be reported through the exec managing director's updates, and we'll have group improvement plans which will report through the strategy plan committee. For the purposes of today, I'm just going to take each improvement plan in turn. For Luft, this is currently an amber rating overall, and it's amber across all of the reporting domains. The two sort of material items I was looking to pull out were the cost improvement plan, which we've talked about at length across a number of items. There's clearly two priorities there. One, closing our gap to plan, which we hope in year and for next year the PwC work will support the trust with, and also trying to improve our proportion of the CIP total that's delivered currently. And colleagues have mentioned we've run an exercise this week through our cost improvement portfolio board looking at the pay non-recurrent revenue. There's around 19 million of the total that's currently non-recurrent across all of our sites, and we think we can flip a large portion of that to recurring revenue. It doesn't improve our bottom line position in year, but it will. Anything that we move to recurrent this year reduce the IP target for next year, so it's clearly beneficial for us to do that. The second item that the paper calls out is around integrated health and social care programme. James has already summarised this very accurately. The two really improvement projects that we are leaning into, one is around brokerage, which is really improving the brokerage function, which we think for those pathway 3 patients, so these are those that will go to a long-term setting or a care home setting, that function working well, and it's transferred from Merseycare to the council, and we're putting more staff and more improvements in, is a very critical project, as is the transfer of care hub. And I think this doesn't directly answer your question, Jeffrey, but in terms of what are the trust doing, we're bringing all of the improvement plans and methodology into those projects. We're doing a review of good practice, what we believe good practice of transferring a care hub and sharing that with partners, and then restructuring the improvement plans. So we really are, for projects that we're not directly leading, we're not being passive partners would be the best way I would describe it. Moving on to the sort of the women's improvement plan, that's a yellow status overall. So it's a very stable, positive delivery position. 3 or 4 areas I'll just draw out. One, we've also had a question on around the long-standing consultant anaesthetist at risk. For colleagues that aren't familiar with this and are seeing it for the first time in papers today, this is around, there's a long-standing risk for the women's site around challenges of recruiting consultant anaesthetists. We are, and the question that's risen is around, are there further details of collaboration between Luft and the women's, really how this is working. At the moment, we have conversations, sort of medical director of the women's to medical director of the Royal site, and we are in the process of putting together a task and finish group to look at further collaboration options and sharing of resources, things like potentially shared roles and shared rotations, etc. So I think that could be a really good example of our shared governance now can move that project forward at pace. The paper also speaks to the blood transfusion robot project. So again, for colleagues that aren't aware, this is a project to procure and install a robot from a German company to bring on-site capability to do blood transfusions in the women's hospital. This isn't actually something that the NHS has done before. This particular piece of kit is used in Europe and it's used in Germany, but it's not we can have one of those from the NHS supply chain. There's more risk involved.
The procurement process had some challenges because there'd been a parting of ways between the two parts of the company that we were due to procure with, one that had the robotic technology and one that had the application to use that in a healthcare environment. We've been doing due diligence with legal support on the part that has the sort of application to do it in a healthcare setting. They formed a new company and we believe that we can now contract with them. But we will running a procurement process because we think both the former company and the new company will want to bid for the service, and we need to run a procurement exercise to test who is best placed, who can provide support, who has appropriate financial standing, all of the things you'd expect to test in a procurement process. So the good news is we think the solution is still available. The downside is we think the procurement will take 3 to 6 months, and then we have 3 months installation. So our best case is sort of 6 months from now. So the solution will go in, but we are readjusting our project timelines to reflect that. There was also a question on the deteriorating patient collaborative, and in particular around the HDU model. Again, for colleagues, the deteriorating patient collaborative is looking at practice around how across the Women's Society we can manage deteriorating patient practice. So that's things like accuracy of observations, management and reporting of early warning scores, compliance with sepsis protocols. And it's also then looking at the medical emergency team capability and the use of HDU. The question is, are there further details of the deteriorating patient model for LWH HDU? The answer is the model is being developed. So again, there are sort of close collaborations with the critical care network and the Royal and Aintree sites and the Women's to look at how that can work. We expect the protocol to be around sort of level 2. Women that meet a level 2 criteria for high dependency criteria would be transferred to the Royal or Aintree sites, but we're working through all of that in due course. The last thing I draw out on the benefits side, and it's also relevant to the NOC3 criteria for the Women's, is the cancer performance. We are seeing improvements in the faster diagnosis standard, so that's at 67.7% for October. Still work to do, but that does bring the trust back on the trajectory that's been agreed with the Cancer Alliance. So that's a positive news. The last thing that the paper talks around is there was an important meeting earlier this month that both trusts had. It was one meeting but split into 2 parts, where each trust had a meeting with the System Oversight Group, which is the trust meeting with colleagues from the ICB and regional team and CQC to look at where is each trust against the exit criteria for moving out of segment 3 of the National Oversight Framework. I won't go into that in detail. The summaries are included are appended to the paper. The work we'd undertaken was supported, and our recommendations around where we think most trusts are against the exit criteria is supported. Summary recommendations were where we are saying the metrics are green, that was accepted. We need to maintain that performance to the end of the financial year. And then we're expecting the remaining system oversight groups to be focusing on the red and amber indicators. So for the Women's, that's majoring on the cancer recovery and the financial position. And for Luft, we can expect that to be significant focus around the financial position. But in general, it was a positive meeting for both trusts involved. And I think I'll pause there, Chair. I hope that's picked up questions and happy to take any questions.
Okay, thank you. Report received. Spoke about the group winter plan, please.
Thank you, Chair. So the things I would like to pick out of the paper is that NHSE provided us with a checklist which contained 10 key areas that we needed to focus on and develop our plan in relation to. 6 of those areas we are directly responsible for as an organisation, and 4 require system and collaborative working. We have included in the plan detailed schemes by hospital And we have clear measures, and the impact has been made explicit what we expect to see from those schemes, and it is presented around the NHS priority areas. The page I'd like to draw your attention to is of 420 of the pack or 19 of the paper, and that contains the summary of the schemes, the financial summary of those schemes, and they include LCL and the need to test patients who are coming through RED, so we can effectively stream those patients to the most appropriate place. And we're working through the costs associated with those schemes with the finance team, and we will be bringing that back at the next board and reporting against that. EPRR will support the operational surge planning, and vaccination programme is firmly in place, and some of the people around this table took the opportunity at the last board to have their vaccination. And there are also some wellbeing initiatives to support staff over the winter period. Corporate and site, hospital arrangements are in place to track and monitor the winter plans, and we will escalate delivery against those plans via the SMB, HMBs and SMB. And the final thing to say is around the risk assessment of delivery of those schemes and the impact. We will need to do a continual risk assessment, whether it's delivering what we expect it to. And obviously, we just don't want any unknown risks emerging over the winter period. The only obvious risk at this moment in time is that some of the areas contained in the winter plan are already being used, given the conversation that we've had earlier. So it's what we would do in times of extremeness, and they're the next stage of the winter plan. All else.
Thank you. I mean, it's a bit clumsy on the governance here. So we're asked as a board to support a decision that the executive's made. So we're neither noting it nor making it. But we're in a sort of grey area of support. What you just said, we don't know how much they're going to cost.
So there's no extent. We do know how much that is definite. That it's just over 2 million. But what we're working through with the finance team is sorry, I'll just pause while Di takes a seat.
Sorry.
Hi, Di. Is there's no external funding allocated, which has been the case in previous years. So that's why we're working with Rob and team of how those will be funded. But we know the cost of the schools, that is definitive.
Just clarity on that, Chair. So previously we have had been supplied by the ICB system, specifically relating to winter. Going into the plan this year, we set aside £2 million to cover winter, which is what we are utilising.
Which questions on the winter plan? Jeffrey.
Just my knowledge really. Has there been any investment on community domiciliary intravenous antibiotics? Because certainly in my previous trust, there was, and it made a big difference in avoiding admissions for people with heart failure or whatever. And they need a great domiciliary team who were fantastic. And we could demonstrate how many days he'd avoided admissions and discharge.
Okay, so I will leave this to Nat, but I think a point of clarity is the winter plan is also supported by the improvement programmes in place, which reading across to what Tim has just reported, Natalie and Pete are leading a very detailed UEC improvement programme, which is not incorporated into here, but it's supporting delivery of the winter plan, and that's been working very closely on what you did that. So over to Nat.
So Jeffrey, at a previous board meeting, we brought back the Newton diagnostic that you'll have heard of mention, and that was a specific thing that they pulled out, is that one of the internal things we could improve is reduce the number of people that stay in hospital for IV antibiotics and make more use of the community OPAT service. So in the metrics we see at our Lustre Improvement Board, we've made improvements in that. The next step
is that actually we are now maximising the use of the community and we need to look at, and we are developing a business case around how we expand that offer, because not only does it need expanding across the board, but there is a much better offer for patients exiting the Royal currently than there is at Aintree. So that is an absolute priority for us, and the next stage is to work with Merseycare around and ourselves around what would we do to take that to the next step, but it would require a level of investment, so that's why I need a detailed business case.
You can save actually on the investment.
Pardon?
You can save, you can demonstrate savings will make.
Yes, and that's why the work through the business case at the minute, absolutely, for that return on investment.
Thanks. Really happy to on this point.
Yeah, it's just so I agree with all of the IV antibiotics. It's on the IV diuretics for heart failure that we have a very effective virtual ward for heart failure patients rather than Aintree for the whole of Luft, and it takes that into account. It's actually very effective in the utilisations over 90%, so it works well.
Great, thank you, Mark. Thank you, thanks, Beth. What demand assumptions have been made and formulated in this plan?
A seasonal, so we've looked at the previous couple of years, and we have based the plans on previous years.
And Jenny?
Yeah, thank you, Chair. And just to draw out as well, it's a group winter plan, but Liverpool Women's within that are very different in the sense of the pressures. So we don't see the same pressures coming to the hospital in winter. Perhaps the organisations above do. Liverpool Women see the spike in neonates in June and in births in September. So whilst we have a winter plan, it does look very different. But Beth's incorporated that in her work as well.
Thank you. Thank you. So what am I to decide? Do we note the decision you've made, or are we committing resources, or what are we doing?
So I think we're just noting that we've made an assumption that winter's going to be very busy. We've also made an assumption that we haven't got anywhere else to put anyone else, but we have put aside 2 million that was already accounted for to try and do those things around the margins that will try and keep us as safe as possible.
Okay, very clear. Thank you. Agreed. EPRR.
Thank you, Chair. So paper included in the pack. I am going to report separately for the two organisations, although we are now working very closely together on making further improvements. So the annual assessment exercise for the EPRR core standards was undertaken in September in both organisations. If you recall, last time the process was strengthened following a pilot in the Midlands, and that required a higher level of evidence to be provided to demonstrate compliance against those standards. Unfortunately, last year, against that strengthened process, we've seen a deterioration in performance, and that was to 18% compliant with the standards at Luft and 7% at the Women's Hospital. So I am delighted to report that significant progress has been made over the last year. We have gone from 18% compliant to 89% compliance in Luft, and that is now given us a rating of full compliance. And at the Women's, it's gone from 7% to 73%, achieving, although the thresholds are very stark, so it's given us a compliance of no compliance, but it has gone from 7 to 73%. Unfortunately, the submission of the self-assessment did rate us as partial compliance, but ICB asked for further evidence, which took us down to 74% at the Women's Hospital. So as I said, we have employed a subject matter expert in EPRR on a fixed term contract until next year, so we can make those further improvements for us to achieve full compliance across all the hospital.
What's the timeline for that? We'll ask you to move.
Be a part of the annual assessment process, which will commence in September 25. We have some work to do between now and then.
Any points, questions, thoughts? Okay. Taken. Is this a new system, Ms. York? Can you compare what the compliance scores are now with what they were this time last year?
No, it's
brand new system.
No, it's always been the same system. It's the evidence that you provide that has been the difference in system. So what they take as us demonstrating our compliance in the self-assessment, that's what's changed. That's what changed.
Worried about it?
No, I wasn't worried about it at the time because it was when it originally happened. It was just a pure case of the goalpost just moved in terms of what the criteria was going to be assessed like overnight. All trusts then suddenly fell into non-compliant and then had to just do more work on their own to get them to compliance. As you can see, looks substantial. The only bit, I wouldn't say I'm worried about it, the only bit we just need to mop up on is that why at the Women's we felt we were compliant, but then the ICB felt with further evidence it wasn't as compliant as we thought it was. So again, as Beth said, subject matter expert looking at that for us now just to make sure that there's anything that needs tidying up, that we tidy it up. So no, I won't lose any sleep.
Okay, thank you. Reid. The next item is clinical negligence scheme for trust maternity incentive scheme update.
Thank you very much. My name's again, I'm grateful that Di Brown's come today to present these two papers.
Thank you, Chair. So,
welcome, Diane.
Thank you. I'm here to present the MIS Year 6 scheme for Liverpool Women's. I will take the paper as read. It's a very detailed paper. It provides an update for October 2024. And of course, this is part of a full year scheme. There's a narrative within the paper about the 10 safety actions as defined within the Year 6 scheme and progressed against each of them. The reporting style for this report is very much defined by the scheme. So you may see that there's potentially more detail in there that you would see in other board papers. That's purposeful because we need to meet the standards as required by board discussions. The paper also provides some details of the financial incentives that are provided by the scheme and recognition of the excellent track record of delivery by the Trust. Each element, which are those safety standards, have been identified as senior lead, and there's a robust governance process in place of oversight of checks and balances to ensure that progress against those standards is being monitored. So in totality, there's local ownership, local monitoring. We also know that we work very closely with the local maternity and neonatal partnership who act on behalf of the ICB and provide monthly check and challenge for each of the details within the schemes. And specifically this year, there's been a focus on the Saving Babies' Lives bundle, which is particularly important because those are standards relating to birth injuries, monitoring during birth, etc., etc. So in the paper, you will see in table 1, there is very detailed narrative against each of the 10 safety actions. There are 3 safety actions that we can declare compliance with already, and the other 3 are on target. There is no risk that I need to bring to the board today in terms of delivery. You will also see within the paper, there is a detailed update on the neonatal nursing and medical workforce assurance paper relating to the BAPA, which is the British Association of Perinatal Medicine, again, a standard that we have to achieve, and you will see a detailed compliance against each of those 10 criteria. Of course, that is also scrutinised by the Regional Neonatal Network, and we are held to account very closely for those standards as well. So in summary, the paper is here as read, good compliance to date, no risks identified to report. We are on track to deliver by year end. There have been several further balance and checks by local external colleagues and regulators, and there will be a oversight of this board discussion in December by the LMNS, and that invite has been made. So happy to take any questions.
Thank you. Jackie, happy?
Yes, so I've had the chance to have a good look at this, and I think I'd just like to come back to the EPRR discussion, if I may. And that is very much around when you're marking your own homework, when you think you've got evidence, it may not be the evidence to the standard that others want. And we went through that very much at Liverpool Women's as we found out that we weren't quite doing the right things. What I'm more confident about now is that we've got a lot more people overseeing the evidence that we've got. So we sometimes, you know, we think we're there and then they'll say, no, you're not quite there yet. So there's a lot of review there. I think the only question I had, Diane, from all this was actually a lot of the stuff is dependent on coming in at the end of November with some audits and so on. So I just was looking for your assurance that that work is has been done and when we might get the results on it.
Yeah, absolutely. So all of the anticipated actions completed in November are on track. There's no issues with those, absolutely not. The only thing that we've done slightly different is that we're having to move some meetings in terms of timescales, but in terms of delivery, all on track, no issues. We are moving Family Health Divisional Board because that's one of the main areas of oversight, just in terms of timescales, but no issues at all.
And I just wondered as well, Chair, if I may, whether it's worth reminding the board about how much we actually pay in dividends to the CNST because it is significant.
Do you like me to? So we're in the region, I think that this year's about £24 million in terms of premium. If you tot it up over the last sort of 8 years, we probably paid somewhere between about 125, 130 million in contributions. The earn back, 10% of the maternity premium we've attracted every year since year one. We didn't meet year one. We were very open and honest about our compliance against the 10 standards, and where we weren't quite sure we could evidence, we declared non-compliance. So we didn't get the incentive scheme for that year. But what happened is subsequently they went back to trusts who had, because we were surprised that we couldn't and others could. And then we ended up with an additional payment from that. So in terms of the earn back from the work that's happened, and this work takes place to try to prevent the harm in the first place and therefore reduce the litigation claims, we earned back more than £10 million over the course of the scheme. It's a significant amount of money for Liverpool.
Very good. Any other? Thank you.
Sorry. Yes. Can I just check in terms of being able to achieve the requirements each year and have the earn back? Does it mean that we have reduced our CNST premium by a penny less percent compared to other trusts who are not meeting it? So the same percentage increase goes up because it goes up by about 7 or 8% a year, isn't it?
It doesn't go up arbitrarily in terms of relation of percentages.
Yeah.
So the premium itself is based on an actuarial calculation based on harm, past events, etc.
Yeah.
The earn back of the premium and the 10 standard meeting isn't impacting on the premium at the moment. It was intended to in terms of reducing the amount of claims and therefore the associated premiums. We've not seen that happening at Liverpool.
Okay. Thank you. Diane, we're still with you, I think, on the perinatal quality surveillance dashboard.
Absolutely. Thank you, Chair. Again, I'll take as read. Again, very prescriptive in terms of presentation and style, in line with expectations. And this dashboard forms reporting key metrics, certainly learning out of Ockenden and other key inquiries. And it also forms a key part of compliance for MIS Year 6 and Safety Action 9 specifically. Very detailed report. There's exceptional reporting in there for those areas where we have a concern. Key messages for this report is that we have seen a reduction in stillbirths. There is a downward trend, and that is positive. And we think as a direct result of the work that we've been doing, certainly around Detain, saving babies' lives, which is around monitoring during labour and pregnancy. You will see that there's been a spike in term admissions for the neonatal intensive care unit. That's under review, certainly by our clinicians. We don't know whether that's just a spike in months, but certainly under review for further investigation. You will see within the paper we are tracking some HR metrics and sickness within our midwifery workforce, just expected. Again, that's under constant review. There's been a significant piece of work to understand, and it relates to long-term sick. And we have been stressing the importance of return to work conversations, and they've increased in compliance significantly in terms of that local conversation within the division. I think the only other area that potentially to highlight in this report is the delays that we see in induction of labour. Induction of labour is increasing in terms of a modality of birth, and we've seen increases up to now 49% in terms of induction rates, and that aligns very much to national practice and is a risk-based approach. It's what we're seeing is the significant variance within that pathway. It is increasing significantly. We've done a lot of work over the last 6 to 12 months. We've increased our capacity, 5 additional beds and spaces, and the relevant staffing to go with that. But as you can see, during our winter pressure period over the summer,
there was some increasing delays with that, and that's something we track daily, weekly, in every sense. And there is a review of every woman that has a delay in her induction of labour. We are continuing to focus on that. And part of our operational planning for the forthcoming year, induction of labour is a key element of that, because we really need to understand the estate, the workforce configuration, to enable us to respond to this different model of care. To support that further, we've commissioned a Birth Rate Plus review. Birth Rate Plus is a evidence-based tool that's used to assess the totality of midwifery staffing. It's advised and recommended that you do a deep dive every 3 years. That is due, and we've commissioned that piece of work, and that's started. So we are anticipating that they will also look at this issue for us in detail and be able to provide some recommendations around staffing.
Anything you want to add, David?
No, I'm just very grateful to present the papers.
Thank you. Points, questions? Yes, Sarah first.
One from me, if I may. We've had this before, just in terms of continuity of data, and it might be because we're talking about adjusted versus non-adjusted, but in your report, you're saying that there's a positive trend on the adjusted stillbirth rate, but in the integrated performance report, there isn't. So we've got a misalignment in the reports, because in the integrated performance report, it's up at 8.2.
Yeah. Yeah,
we'll have a look at the quality of the data.
Definitely.
Okay, that's out. Thank you. Any other point? David?
Yeah, I'd just ask the midwifery sickness levels are surprising. You say you're looking at it. Stark contrast. You look at the obstetric medical sickness levels. They're a fraction of the midwifery ones. So just is there anything about the work environment or anything behind that?
So I suppose they are predominantly long-term sick. So that's either a long-term condition. There's some significant surgery in there. There's some cancer in there. There's a whole range of things, but it's long-term, so it's not short-term, and that's very different. In terms of working conditions, there's always a question whether or not people feel supported and comfortable at work. We've got 0 vacancies. We're actually over-recruited. We over-recruit for maternity leave. So that's an unusual position to be in terms of a clinical workforce. The feedback that we get from our staff survey is pretty average. It's okay. We're not having concerns raised through any of our channels. So I don't think that is a particular issue for this element of sickness. I think it's very much more related to some individuals who we are supporting with long-term conditions.
Well received. Very much.
Thank you very much, Dave.
The Learning from Death Annual Report, Jim.
Thank you very much, Chair. This is the Learning from Death Annual Report for 2023-24. There's a few headline figures in here. You'll see what appears to be a reduction in crude mortality, and is showing a 1.5% crude mortality rate. That means one of two things: either fewer people have died, or the denominator has got bigger. And actually, the number of deaths has come down a little bit. In 2023, there were 3,567 deaths through our mortuary services. Some of those are actually home office deaths, which fit outside hospital. But actually, that is a slight reduction. But I think, to be honest, the reduction in crude increased out. There's been more throughput through the hospital. That there's an association with the opening of the new Royal, so we'll have a good look at that, but I think it is an association. So anyway, it's interesting things to look at. Shimmy continues to stay under 100, 97.09, NHS MR 97. So statistically, I feel I can give you assurance about that. We had a look at deaths by deprivation quintile to make sure or see whether any inequalities in the way this piece is working. And you'll see again, we've got a high proportion of deaths of patients who are in the bottom quintile for deprivation, but you'll also see that relates to our activity. And that tells us something about the population that is low, and that appears to match up. But I think it adds to that narrative about the work that we do as a pre-hospital trust in deprivation. We are monitoring a few new statistical outliers, so in particular at the moment, biliary tract disease. And as ever, what we do is we get alerted to a statistical outlier. We then get our
Learning from Death's team to have a close look, to make sure the coding is correct and to deep dive into the system. So that's what's underway at the moment. And I've reported that we've looked at a number of other clinical areas over the year: circulatory disease, pancreatic disorders, esophageal disorders, appendicitis and appendiceal disorders. It's my experience, Chair, that these data outliers come at you it feels rather random. You know, something will come from HES. It's an opportunity for us to review, and that's what we did in this case. I've reported before that we were alerted by the Stroke Sentinel audit that we were potentially a outlier for stroke. So we've had a good look at stroke, and I've put that narrative in the report. We put that narrative in. We found a lot of interesting coding issues around stroke, and in particular around atrial fibrillation and atrial flutter. So cardiac arrhythmias have been an important risk profiling in stroke, which we haven't captured effectively. So I believe we've put that right. See, I've talked about some actions which the stroke team put in now in terms of a snap lead and better emphasis on coding. And that now looks as if our mortality for stroke meeting the national norm. And looking at the data for, as it were, this year moving forward, I think we will see further improvement in that space. So I've received assurance that we're looking good in that way. We've hit more than 60% of primary mortality reviews on every site. That was our declared target. We agreed that with our commissioners. So very pleased with that, and that amounts to 2,538 cases being reviewed. In the thematic reviews coming out, we're seeing more around medication, which is interesting. So our reviewers saying they're seeing things about medication which is of note. That doesn't necessarily mean they translate into causes of death or suboptimal care. I think what it translates into is that our clinical teams are taking full focus on that area, undoubtedly encouraged by our chief pharmacist and the team. So I think that's to be welcomed. Although we say in the paper that we think the palliative care issues are less prominent, I think if you look at that in more detail and you look at us thinking about palliative care, end-of-life decisions, a recognition of the dying patient, unnecessary intervention, ceilings of care, actually, I think this is still a massive issue for them. Colleagues will know, that we've got some anxieties about the provision of palliative care across the whole system, as we actually bearing on our bed usage and so on, actually on late discharges and so forth. So I do think in a system sense, that is still a big issue for us, and it's still a big issue for the system. We've done a bit more work on the governance structures, and we've got a mortality assurance group now, which has a lay input into it. So one of our patient safety partners, who's a lay member, joins that group. So we think that gives us a different level of scrutiny and assurance into that piece. And this will be relevant to our ongoing work with Liverpool Women's Hospital as well, is linking this to the PSERV work, so that we've got a common approach to the way we look at incidents and review things in a common way, and we look for system causes and so forth. So we have a bit of work to do, I think, in the coming year to keep refining these models, giving appropriate assurance. But I hope, Chair, you'll agree that's a good summary of the work. Doing a very good summary and good paper. Points, questions? Oh. Yes, Jenny.
Just to be clear, I don't know if you said this at the start, Jim, and I didn't catch it, but Liverpool Women's Learning from Death has already been supported, which is why it's not here today.
So I just wanted to talk a little bit around the coding, the quality and depth of coding, because obviously you're getting outlier alerts, but then when you look at it, it's not an issue. It's about the process that's gone in. So I just wonder what investment you're doing to make sure that the people coding are of the right standard. Because as you know, in America, that's what runs the system of the payments. So if they make sure theirs is absolutely spot on to get the payments. So How do we deal with that?
I might ask my colleague Matt to come in here a little bit, but we are constantly reassured that our levels of coding are good, and there is feedback for the past the system. And I think, I suppose the coding can only be as good as the clinical information that's put in. And when we scrutinise this with clinicians, so our scrutiny is by a consultant, plus training up to do that, then it's kind of falls back to, did the clinical team really put the right principal diagnosis in, the right morbidities in? Putting the morbidities in, the comorbidities is key, actually. It's actually key to getting the shimmy right, because that's partly how the statistical model works. So I think our coding is pretty good, please must say it like that. But of course, we think there's some challenges because of our electronic patient record and so forth.
Yeah, if I can just add, first of all, we do undertake external assurance around our coding, and we have received substantial assurance around our clinical coding standards. With Jim's right, I think this really ties back to some of our digital capabilities and the code standards that we get within our system. So as we move forward with our new digital systems, that will obviously help. And then, of course, we've already heard, haven't we, about artificial intelligence opportunities to really help along with those sort of manual processes too. So we have to see a digital influence on that in the future.
Peter?
It's just really on your point, Jackie. I think some of that both bears out with the stroke work, and actually, this would predate the stroke assessment centre. You filter everyone through that, the coding goes up because it's not much more interested in it. So I agree with Jim. It's the connect.
Thank you. Good report, very clear. When I read it, I felt very uncomfortable about the deaths identified through delayed discharge and unnecessary admission. And I hope that's fed back to the ICB project, trying to accelerate discharge. Just jumped out at me there.
Any other? It's a very good report. Thank you, Jim. Violence prevention and reduction standards.
Thank you very much, Chair. Colleagues may recall that earlier on this calendar year, I brought a paper identifying a self-assessment the organisation made against standards for 2020 around violence and aggression reduction within hospitals, being published by NHS England, where we deemed ourselves on a self-assessment to be compliant. But you may also recall that at that point I said that a new set of standards that we were anticipating to have been published quite shortly after that date. However, because of the general election, that was all held up and they still haven't published. What we know about the new standards when they do become enacted is that there's an expectation of a self-assessment process. A peer assessment process each year as well. And with that in mind, the organisation decided we would go along with that, even though the national guidance wasn't out. And so we asked colleagues from the security service, from Betsy Cadwallader, to come and provide that assessment. We did that for a number of reasons. We chose that organisation for a number of reasons. They are an organisation that obviously don't sit within England and will be looking with a different set of criteria and eyes around the criteria we are expected to have. And also they are a large organisation and are on the terms as well. And it gave us some assurance. The review from Betsy Cadwallader, they also gave us assurance of our compliance against the 43 indicators of those standards, and that was pleasing. However, we recognised as an organisation that we need to change our focus, how we look at violence and aggression within the organisation. It's been led very, very well by our security services, but we recognise that it needs to be a much wider focus on how we look at the reduction methodology and how and who we should be including within some of those actions to make change. And so we've moved the coordinating group into an executive led group by myself, and we are focusing on the cultural work that the organisation is doing through the improvement plan, but also staff wellbeing being at the heart of what we and obviously significantly that we provide a safe environment for the people of our organisation to receive care. So it isn't simply around I'll use very basic explanations. It's not around just putting warnings down. It's around we don't tolerate poor behaviour and actions against our staff. It's around looking at what environments do we provide for people who are coming into our services, and those environments themselves contribute to people feeling unhappy or anxious about coming into hospital. Are we providing enough and appropriate education to the people who are providing care so that they are not antecedent any behaviours with patients because of the way in which patients are approached? Are we looking after people who have been the victim of any violent or aggressive behaviour, and how are we supporting them in that recovery? How we are learning from that, and also how we helping rehabilitate into work. And so the that group itself is taking a lot of action. We've been meeting fortnightly for the past 3 months. We're now moving into a monthly phase, and from the beginning of the calendar, sharing with the organisation a whole series of actions and initiatives that are going to be that are being launched. So whether it's around body cameras and how we're going to monitor that, whether it's around the use of the ICON training for de-escalating behaviours within a clinical practice, whether it's around the education offer to our staff, the environment in which we care. We are including lots of our clinical and non-clinical staff in development of those initiatives. As soon as we get the new standards published, we will be monitoring ourselves against those. There'll be further back, and I would anticipate if board 6 months time.
And a good proposal, David, thank you. And for newer board members, this was something that we discussed at Luft a while ago and asked for to come back with more answers to the questions we represent. Very well. Any further points? Good, thank you, David.
Very much.
Well done. Daniel, can you, I'm conscious of my failings in time management this morning. Can you walk us through the section?
Really quickly. So basically, we're bringing a brand new corporate governance manual which consolidates the arrangements that were in both Liverpool Women's and LUF. Basically, it unifies the governance framework, emphasising the decision-making processes, performance management, and also how we comply with various NHS regulations. In a kind of way, it also highlights the legal autonomy of both organisations and where we have issues such as reserved functions that we have to keep separately in terms of forming a group. Just wanted to make sure board members should note the emphasis on the risk management approach that we adopt across all members of the group, and we've seen that highlighted in the reporting so far during this board meeting. And also the regulatory requirements and strategic alignment. We've made sure in the last couple of weeks it aligns with a recently published document from NHS England, which was titled Insightful Board. So in that document from NHS England, they've highlighted things that boards should be looking for, questions that they should be asking, and we've just made sure there is alignment with that. In constructing the document, we've gone through sort of consultation and reviews internally, through a senior management board, through the Liverpool Women's Hospital Management Board, and also the Executive Directors Group. It was also circulated to non-executives. for comments in advance of today. The only thing in the appendices, which are part of the information pack for today, there's a series of documents that are included. One of the things that was missing was in relation to the scheme delegation and standing financial instructions for Liverpool Women's. The Loft documents, there has been no change. In relation to Liverpool Women's, there's been a review that was, a discussion was held, I think it was yesterday, with Tracy as chair of the Liverpool Women's Audit Committee. In terms of the changes, we've tried to bring Liverpool Women's version in line with the version for Loft. It removed quite a lot of, I suppose, operational detail that was in the previous version. We have copies today if board members wish to see the actual details of the changes, but we will circulate those separately after the meeting. I don't know, Tracy, if you wanted to make any comments, or Rob or Jenny, on the changes.
We've had a good conversation around it, and I think we went through it. I think there were some small differences on budgetary levels, weren't there, but, operationally, which made sense for Liverpool Women's. But apart from that, where we could, we kept everything, I think, in delegation the same, as I understand from the conversation we had yesterday. I think the only thing I've got is around process. I think Rob and I had a discussion around how we do this, because usually this would go through audit committee and then go to board, and obviously it's coming to board here. But on a practical point of view, you want something to work to now, really, otherwise it's going to be confusing. We were talking about actually how we should go about that, and I think we should be approving it today as a working document. I think then that just allows everyone to have another look at it, because I think we're 98-99% of the way there, and then that allows it to go, have anybody else to have a look at it and feedback any comments, but also for it to go to audit committee in January, and then we just do the final sign off. But we've got to have something to work to.
Okay.
So
pending that audit consideration, I'll leave the new calendar. Are you happy with that, Rob?
Yeah, no, absolutely. And we've mapped everything across from the Liverpool Women's SFIs into the new format, which again, the format is consistent with the LUF format that obviously gets scrutinised annually at our audit committee. So the format is a good one. So absolutely, if we could have that as a approved working document, we'll take it back through the audit.
Any intent, James? Yeah, good suggestion. We approve. Thank you. Right, Daniel.
Okay, the next one is in relation to the assurance reports included for the Love Charitable Funds Committee. David chaired that committee. David, I don't know if there's any particular highlights that you want to make, or if the report is fine.
Just like to call out their chairman, the Sunshine Group, which supports breast cancer patients through their cancer journey. So they act under the auspices of the Love charity, and they received the King's Award for Voluntary Services. Reported to the committee, a great achievement. I think that deserves recognition. Other than that, happy to take questions from the paper.
Thank you. So, yeah, anything you want to? Everyone content? Thank you. Bottom, David.
The next item, Chris is just going to update on the charitable funds accounts for Love.
Time Chair, I'm quite happy to say unqualified opinion. There were three recommendations in the annual report, all that were on with it progressing in the current financial year. So I think all in good health, but despite extensive expenditure over and above income last year, was still a going concern, which is a positive place today.
A summary of most of the agenda that we've discussed. Thank you. Rob, are you happy with it?
Yes, absolutely.
Thank you, David. Chrissy. Thank you. Okay, well done, Chris.
We now move on to Liverpool Women's, and obviously these are areas that are reserved functions. In terms of the board assurance framework, we've updated the board assurance framework for Q2. What we've agreed is that we will maintain two separate board assurance frameworks for the remainder of this business year. we will be doing some work at the board development session next week to start looking at frameworks, equivalent organisations and the ICB, and then with the aim to agreeing a new board assurance framework for the group next February. So we're maintaining the two and we'll continue to report on those during Q3 and Q4. In the last quarter, we're proposing that there are two changes to the risk levels. Both of them have the scores reduced ever so slightly. One is risk 5 on the cancer recovery, where we've heard about the progress that's been made, and reduces risk from a 10 to a 9, basically because of the strengthened controls that are in place and the actions to deliver those. And the other one was on waiting times, again reduced from a 10 to a 9, and again because of improved controls. The remaining 7 risks remain unchanged, of which one is significant, which relates to risk 2 of the isolated site, and there are 5 serious risks which remain as they are. We will continue to, the BAF risks will be managed through the hospital leadership team groups. They will be confirmed by the hospital management board, chaired by obviously the managing director, and they'll continue to come here from Q3, Q4. So just for approval.
That's approved, please. Makes sense. Yep. Everyone happy? Thank you.
We've also brought back the minutes of the last audit committee. I know Tracy's touched on those. I don't know if there's anything, Tracy, that you wanted to highlight and specifically from the assurance report.
No, I don't think so. I think when we talked about the issue around external audit.
Okay.
And also the Charitable Funds Committee report that was chaired by Zia. Zia, I don't know if there's any issues that you want to highlight.
There was further report.
The only issue I wanted to raise on the charitable funds is obviously at the Charitable Funds Committee, we reviewed the annual accounts. They're currently receiving some review by the independent auditors, and they're scheduled to come back to the board as trustees for them for us to approve formally at the December meeting.
Very clear. Thank you. Well done. All good. On the consent agenda, we papers from the Liverpool adult acute specialist providing joint. Make more reference to that when we get into the next part of our day. Register of interest there. So anything anybody wishes to raise that we can't be able to join. Okay, thank you very much. Meeting closed.
I think that there's a answer the questions being answered. There's a difficulty about hearing in this field. There's a background hum. I don't know if it's heating or the building.
Not that you
it probably wasn't.
Yes.
One of our members of the public decided to leave at the break because it was becoming quite difficult to hear things softly. So you need to consider that in the next meeting.
Danny, if you ask someone to pick that up outside of the meeting.
We'll try and pick that up.
Yeah. It's what the bell is ringing intermittently because Jeffrey's iPad.
Can't figure out why. It's not an expert next one. He can't figure out why.
I didn't want to meddle in case I made it worse.
I do.
Someone's emailed the
emails.
What email?
Oh, I'm email.
Okay.
Frost alarm on the thermostat.
Right, thank you. We'll have a short break. We'll resume again in. I was going to get. Excuse me. We'll resume again.